Welcome to today's webinar, which is being held on the occasion of Safe Motherhood Day. It's a very great privilege to have all the stalwarts of Ksoga and also Foxy for today's function. So we'll start, and special thing about today's webinar is today is the first webinar of the new office bearers. So I welcome you all to today's session. We'll start the session by invoking God. Arun, please play the prayer song.
कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः.
Thank you, Arun. So I would take this opportunity to welcome everybody. First of all, I would like to welcome Dr. M.G. Hiremat sir, who is the chief patron of Ksoga, though he's not there because of some family function. But we'll always remember him because he is the support and he is the inspiration behind all of us. I welcome you, sir. I also welcome Dr. Nagraj sir, who is also the patron of Ksoga. I welcome Dr. Bella sir, who is the chief guest for today's program. And I also welcome Dr. Vidya Tobbi madam, who is the immediate past president, and Dr. Bharti Rajshekar madam, who is the president newly installed. And also Dr. Durga Das sir, who is the president-elect. I also take this opportunity to welcome Dr. Rajashri Paladi madam, who is the secretary, and Dr. Suman Gaddi madam, who is the treasurer of Ksoga. All these leaders of Ksoga are very supportive and pushing all the youngsters like us to go and do something and learn and teach and do some difference in this one. I thank all of you for being there today on this Safe Motherhood Day webinar. Also welcome Dr. Shanta Shekhar madam, who is the EC member, and also Dr. Preeti Kumar madam, who is past chairperson of Safe Motherhood Committee and has done a wonderful job. Also take this opportunity to welcome all the members of Safe Motherhood Committee and the esteemed speakers, Dr. Hema Madam, who is the great icon of Ksoga and Foxy, and also other speakers, Dr. Shobha Gudi Madam and Dr. Babu K. Sir. And I also welcome all the delegates for this today's session. Hello, Madam. Madam, open link ಕಳಿಸಿದ್ದೀನಿ ಮೇಡಮ್ ನಿಮಗೆ ನೋಡಿ ಕಳಿಸಿದ್ದೀನಿ. As our chief guest has not yet joined, we'll move over to the guest of honor. I call upon Dr. Rajashri Paladi madam to introduce our guest of honor, Dr. Preeti Kumar madam.
Pranamams. Good afternoon to everybody and welcome to the webinar on the Safe Motherhood Day celebration. And I heartily congratulate Dr. Bharti Rajshekar madam again for taking up as the president of Ksoga, and the first webinar under her presidentship is this day today. It's a proud privilege to be introducing Dr. Preeti Kumar to the audience here, because Preeti is so wonderfully known. She's full of love and affection, just as her name denotes, that she just spreads in the knowledge with so much of love and care. And we have seen her dedication towards the work when the Visit program was floated in Karnataka. And I have seen so much of commitment in her work. And I think that is the best description that I can give to her until her slides open up. She is the past chair of the Safe Motherhood Committee of Foxy, and being doing dedicated work and services, connecting people all over the world, and trying to get in the best of the heads and best of the minds to implement the programs which were so meaningful to bring in. We always think of the patients who are affected, but then this program was what was training the caretakers to do the best of the services. And Dr. Preeti has been one of them. And she's a very active member and very progressive leader in Foxy, working from Lucknow, and right now we saw that she has hands full on her desk and doing so much of work. Uh, Arun, Dr. Preeti's line, please.
No, I think it's enough, Dr. Rashri. I'm part of Ksoga. I think I'm part of Ksoga.
No, no.
So that
It
introduction
requires
is
a
more than
formal
enough.
introduction of your
Yeah.
achievements, of your contributions,
It's,
of your degrees, and I think Arun is taking time to open up because of
it's
9 months.
okay. It's okay.
Arun,
It's okay. I'm
please
always there for
share
Ksoga.
the screen.
Yeah. Am I audible?
Yes, yes,
So
you are.
first, I would like to thank Dr. MG Hiramat sir. Please don't put my CV on. Let it be. Yeah, yeah. So, first and foremost, I'm thankful to Dr. MG Hiramat sir because I think he's the person who connected me actually to Ksoga. I knew so many of them, but first time when I got a call from him, he said, Preeti, I want to introduce Dr. Sonia, and she is the chairperson. She has taken over as the chairperson, and whatever you do, please involve her. And immediately next day, I added her in my Safe Motherhood Committee group. And then Shobha came in, and so kind of a connection that built, with Ksoga. And it's a, intense bonding, I must say. I'm so much affection and love I get from Ksoga. So I'm thankful to Dr. Vidya Thobi because she took over as a president, and then immediately she started Foxy Vistrit Ksoga, and Dr. MG Hiramat sir, because we did a similar project in Jharkhand that was on GDM and anemia. Then he said, you should better at hypertensive disorders in pregnancy. So we did that. And probably if I get some time, we have the data in hand. We will definitely publish it in Jogi. Congratulations to both the leaders, Dr. Vidya Thobi and the incoming president dynamic, whom I now know much better, Dr. Bharti Rajshekhar. A lot of committed work she has done in the past from the Hassan Society. And I wish to see her progress more in Foxy, and probably she will. And also congratulate Dr. Durga Das sir for as the incoming president-elect. I know Ksoga is doing wonderful work. But just I want to, I was going through the program agenda. You have kept two topics on cesarean section, reducing the rates of cesarean section, and also the techniques. But yesterday, I would like to share my experiences. UP government has given me the responsibility of two important districts in UP. One is Sitapur and one is Fatehpur, which have very, very high maternal mortality. And I have been given responsibility to train the private sector for the antenatal, intrapartum, and postpartum care, along with the cancer prevention. So yesterday I went to have a meeting. I had a meeting with the CMO of Sitapur. I went there, and all the 9-10 facilities were called. And you will not believe all 10 facilities are providing antenatal, intrapartum, even cesarean sections, but none of them were MD or qualified doctors. They were Ayush doctors, they were BUMS doctors, BMS doctors, and some were surgeons. There was one lady doctor who was surgeon. So then I thought, what a big challenge I have taken on my head. Like, they are nowhere, they don't know anything about the antenatal, but still they have a high delivery load. They are conducting the deliveries, they're doing the cesarean sections. And when I came back, I was just thinking in my mind, how will I go ahead with these? Because this is a pilot project in UP. UP still has a maternal mortality of 167. And these two districts are the pilots which Japaigo is supporting and UP government is supporting. And I'm taking a challenge to train those almost 30-35 facilities. So this kind of scenario still exists. So I will request Sonia and Shobha, you are young. You do these webinars. These are good for OBGYNs, but please try to collect some data from Karnataka. Just start from small societies, all the private sectors who are doing cesarean sections. What are the indications? And then try to analyze why cesarean sections are so high. What are the particular indications where the cesarean sections are high? So even if you can start from Mysore, or you can start from your own society and start collecting data from the private sector, and then you also collect data from the public sector. Just try to analyze just one district, and then it will give you a lot of insight how to go about, what are the basically where the patients are having complication, and what best we can do. So this is my input on this, and I know there are wonderful speakers today. Dr. Hema Divakar, she's the best one to talk about the skill transfers digitally how we can transfer the skills to the participants. And this Jeevan project, which I'm doing in Sitapur, Fatehpur, is virtual as well as online. And then Dr. Shobha Gudi, she's a wonderful speaker, and she definitely will touch upon important points on how we can reduce, and Dr. Babu, who will talk about the techniques of cesarean sections. So as a Dr. Bharti, I would suggest if you can just take out one paper from Karnataka on cesarean, that would be a great achievement for you. So maybe from smaller districts, even Hassan you can collect, or anywhere, and just show how and try to analyze how things are moving in this. This is what I'm trying to do in UP. So if the leaders start doing like this, we will have something concrete to talk about actually why the cesarean sections are so high, and how we can reduce the rates of the cesarean sections in our country. So thank you so much, and thank you, Dr. Rajshri Palladi, for your kind introduction, and Dr. Suman Gadi, always very silent, but she's always very supportive all the time. Thank you, everyone. Thank you, Ksoga, for inviting me and giving me this honor of guest of honor. Thank you so much.
Thank you. Thank you, Dr.
Thank you.
Preeti. I am traveling.
Thank you, madam. Now I call upon Dr. Suman Gaddi, madam, to introduce our another guest of honor, our very dynamic and vibrant leader, Dr. Bharti Rajshekar, madam.
Thank you. Yeah, good evening, one and all. Namaste. Yeah, it's my proud privilege to introduce Dr. none other than Dr. Bharti Rajshekar. All of you must be knowing that Madam has taken up the presidentship Ksoga for the year 24-25. Earlier, Madam was president-elect for Ksoga 23-24. And, to reach this stage of President Ksoga, a lot of hard work, commitment definitely has been involved. And Madam, of course, to reach this stage has done a lot of work. And congratulations, Madam, once again, to come to the post, and all the very best for your tenure.
Thank you.
Madam has many accolades to her credit, starting from
I think Dr.
the
Suman,
IMA level.
Dr.
Very
Suman,
brief, because this is my first introduction to you after you've taken charge. So
okay,
all
thank you.
must know about it. So at the IMA level, of course, was very active. Madam was very active, was the past vice president there. And Madam was the EC member of Women's Doctors Wing at IMA. At Hassan, Madam, I'm sure Madam has started her ground level at Hassan itself. And was a past president and past secretary of Hassan Society, and is the committee member of PCPNDT Hassan. At Foxy level, Madam has also done a lot of work, organized the first Foxy satellite conference in 2006 in Hassan, organized Red Alert workshop with Dr. Pankaj Desai from Hassan Master Control Facility, organized Ksoga State Conference in 2010. Then Madam is the South Zone Coordinator for Foxy Public Awareness Committee and Oncology Committee member. And then Foxy Food and Medical Equipment and Drug Committee member, Madam is there still. And then Madam is trainer for Foxy Dhira and RAC programs. And regarding awards and activities, of course, Madam is the President Medal from was the topper in final MBBS, Madras University. And as president of Hassan Society, Madam has got the President Rotating Trophy, as well as when Madam was secretary, also bagged the President Rotating Trophy for Hassan Society, and also received the DK Tang Award while she was secretary as well as president of Hassan Society, and recipient of Rajyotsav's Award for the work in healthcare at Hassan. Apart from this, Madam is actively, all of us know that Madam is actively involved in the adolescent health awareness activities as well as cancer cervix screening camps. And of course, Madam is active in this HPV vaccination, which is giving free of cost for the immunocompromised patients. Now, special interest, regarding the special interest in non-communicable diseases, and got special interest in adolescent health and high-risk pregnancy, preventing oncology, geriatric health in women, also in family welfare and contraception. So this is Madam's CV, and I really, Madam, I wish you all the very best, and so that you can take the Ksoga at higher heights.
Thank you, Dr. Suman, for that elaborate and loving introduction. And at the outset, I express my heartfelt thanks and gratitude to all my dear Ksogians, with whose support I now address all of you as the president of the KCOGA. And this happens to be my first webinar. And what other webinar could we do rather than the Safe Motherhood program as the first program? So I am indebted to all my members, especially my chief patron, Dr. M.G. Hiramat, who has mentored me, Dr. Nagraj, who has always been a guiding force to me, and all the 14 presidents prior to me taking over as the 15th, from Dr. Pushpa Srinivas, Dr. Hema Divakar, Dr. Ambrish. There is a huge line of presidents who have been guiding us and setting the bar, and my immediate predecessor, Dr. Vidya Tobi. I am grateful to all of you. And of course, Dr. Preeti Kumar has done a wonderful job in the Safe Motherhood as a chairperson, and also now that she is heading the perinatal and maternal health chairmanship of this FOG, and she continues to do this work to train and see that we transfer skills so that our women receive better care and we can reduce the maternal morbidity and mortality all over the country. And Dr. Preeti, I assure you on this platform that we will definitely get into this program of doing an audit of the cesareans and the indications and the complications we are facing during and after the cesareans. And we will try to coordinate that with you. And also, you have just told that you have been given the pilot task of training these non-obstetricians in maternal health. And if there is anything that from Ksoga we could do to help you, we are all welcome. And you know that are my young Turks, Shobha, Sonia, Rachana, and then many, many more. We will definitely be with you, especially if there is any digital transfer of skill under the guidance of Dr. Hema. We will definitely be there. Please count Ksoga in any part of the country. We will surely try to help you.
Thank you so much, Dr. Bharti.
And well, I would just like to give a brief because this happens to be my first webinar, and many of them did miss my installation, which was a very grand success at Manipal. I would just present 2 minutes what is my mission for 2024 and 25, if you permit me to share my screen. So my mission for the 24-25, just a minute. Yeah. Am I visible? Shobha?
No, madam, not yet.
The slides?
Double click, ma'am.
Not
Slides
yet.
are not visible. Yes, ma'am.
Now
Make it
it's
Yes, ma'am.
Yeah, now they're visible, right?
Yes.
Make it full screen.
Thank
Make
you.
it full Make it
So,
full
well, I'm
screen.
just going to take 2 minutes. I'm not going to play all the slides over here because that will take a long time. So what I want to tell you is my mission, what I'm going to have for this year is with the blessings of the Almighty and the blessings of Ma Saraswati. I would like to say that let us put the knowledge we have received into good use. So with my pranams to all the predecessors, as I already told you, and my mentors and my team of Ksoga with the KCOG team. And we have a very vast association of 22 societies and 21 committees and about 3,400 members. These are all the office bearers. I'm not going to go all. This was done for my activities in my presentation in Manipal. So I had paucity of time, so I could not edit it. So my vision is going to be promote wellness and prevent illness. So to promote wellness is we have to start very early from the fetus, which is unborn. So we have to start with nutrition awareness, lifestyle management, screening for women for cancers, and vaccinations, so that we see that this woman is healthy in all the 6 dimensions of intellectual health, spiritual, emotional, occupational, physical, and social health. So in this we will focus mainly on anemia screening and management, because you know that anemia is the predecessor of many diseases, including the increased instance of infant mortality, morbidity, and maternal morbidity and mortality. So if we strike at the root of anemia, definitely we will be able to reduce the other indices also. And of course, cancer prevention of breast and cancer prevention, and preconception care and safe motherhood protocols. We are planning to put across protocols in safe motherhood management to all our members of Ksoga, so that we have a uniform code of practice all over the state, and that will be utilized so that we can manage them effectively. So I'm not going to go into this. The other thing is we want to do is educate women, of course, and give her safety, but we are going to conduct the Dhira programs and other programs. And along with that, we will be bringing out webinars, ready reckoners with standard practice protocols, and we plan to have an emergency pan-Karnataka helpline where all obstetricians, especially with the young ones or those who do not have any access to any help, they can always give us a call to help them out in at least digitally for any guidance for an obstetric emergency, medical legal help, or for mob violence. And we are going to continue with our activities. So we hope to bring about these changes. So I'm not going to go. So the mission is going to be promote wellness. So I request all my Ksogians, please focus on holistic health. Please talk about prevention. Try to screen each and every woman who comes to your clinic for anemia, for cancers, and do a per speculum examination for every woman who enters your clinic. And also talk to the adolescents even before they are married about the preconception, about vaccination of especially the HPV vaccination, and also talk to them about preconception, the importance of folic acid, importance of having their hemoglobin and thyroid in the normal ranges, so that they can have a healthy baby and we can reduce the mortality. And Dr. Vidya, this program was scheduled on April 11th on Safe Motherhood Day, but because of everybody's inconveniences, we had to postpone it. So Dr. Shobha and Dr. Sonia have put up a very good program of the digital transfer of skills for safe motherhood, which will be by none other than Dr. Hema Divakar, who is the doyen in that. And I think that is the way forward, because we know that under the stewardship of Dr. Preeti and Dr. Hema, we have done a lot of Manyata programs and the Vistrit programs in Karnataka. We have trained our healthcare personnel as well as our clinical assistants and our obstetricians in practicing with protocols in safe motherhood. But still, there is much to be done in Karnataka, because we have not registered all our centers under the Manyata program. So I also appeal that let us all try to motivate and sensitize. And our immediate past president, Dr. Vidya Tobi, happens to be the coordinator for the Manyata program in Karnataka. So we aim to sensitize all our obstetricians and see that all nursing homes, small and corporate hospitals, take up this Manyata certification program for the benefit of their healthcare workers, so that they can sleep peacefully every time they have an obstetric case in the labor room, or they have delivered and they have gone back. Because if they are trained under the Vistrit and the Manyata program, they will know the protocols, they will manage, and they will be on their toes whenever there is a complication. And that saves many women and saves many headaches and stress for the obstetricians. So this is a sincere appeal from my part. Please get your healthcare staff trained. Then we have Dr. Shobha Gudi, who is an excellent, crisp, and very speaks with a lot of clarity, clearing all the doubts. And she is going to speak about the how to reduce the rising trends of cesarean sections. And we have Dr. Babu, who will be talking about the procedures and the problems we can face during a cesarean section. So I wish this webinar a grand success. And I request all of you to participate proactively, not only as faculty, but also as participants. And also we will be doing a lot of physical programs in my tenure. We request all of you to participate and take this across to your women who come to you in their times of difficulties. And also we request you that if you have any suggestions, kindly put it across to us, and we will try to discuss that in the EC committee and try to do those things so that it will benefit all of my fellow Ksogians. Thank you, Dr. Vidya Tobi, Dr. Shobha, and Dr. Sonia for giving me this opportunity, and wishing you this webinar a great success.
Thank you very much, madam, for your encouragement and for your vision. We'll definitely have very good guidance from you in doing our future endeavors. Now I call upon Dr. Nagaratna Kuntoji, madam, who is the president of Bagalkot Society, to introduce Dr. Durga Das sir, our another guest of honor. Nagaratna, madam.
Hello,
Oh, madam.
can you hear?
Yes, madam, you are audible.
Yeah, good evening, everybody. It's my privilege to introduce Durga President from 2024 to 25, that's the next year. And he is the treasurer. He was treasurer of Ksoga from 2020 to 2022. And he was EC member of Ksoga from 18 to 20. He was the past president of Tumkur Society, and he is working as associate in Siddhartha Medical College. And he is also a consultant at Kasturba Hospital. So next, after Bharti Madam, we are going to see you as the president of Kasturba, sir. We heartily welcome you, and nice to have you on the board.
Thank you. Good evening, everybody. At the outset, I congratulate Dr. Bharati, the whole new team of Ksoga and KCOG. Dr. Bharati is the president, Dr. Vidya Tubbi as the immediate past president, secretary, Dr. Rajashri, treasurer, Dr. Suman Bedi, and KCOG dean, my friend, Dr. Bella, chairperson, Dr. Vidya Bhatt, and secretary, Dr. Sonia Mandapa. Presently, I acknowledge the presence of Dr. Preeti Kumar. He's a wonderful worker, very hard worker we have seen. She was as a chairperson of Safe Motherhood. She has put up such so many good programs. The Visit program, my hospital is one of the beneficiary of that program. I know after our staff got training from that program, the quality of the work of our junior doctors and the staff has increased so enormous. It was a very disciplined program. For that, I have to thank Dr. Preeti Kumar, and because of your hard work, the government of UP has chosen you for such a mammoth task of about cesarean section in Uttar Pradesh. I don't want to talk much. We are all eagerly waiting to listen from the good speakers, Dr. Hema Divakar, Dr. Shobha Gudi, and Dr. Basu. Here, now I have to congratulate two youngsters, Dr. Sonia Mandappa and Shobha Savi. You are really wonderful workers, so disciplined. I am seeing a great future in you. All the best for you. With these few words, once again, I thank the organizers for giving me this opportunity. Thank you.
Thank you very much, sir, for your encouragement. Our chief guest, Dr. Balla sir, will be joining shortly. Till then, we'll start the session. For the first talk, which will be by Dr. Shobha Gudi madam, I call upon Dr. Rajashri madam to be the chairperson. I call upon Dr. Hema Patil to introduce Dr. Rajashri Paladi madam. And I can also see Kasturi Donimat madam, who is also the past president of Ksoga. Madam, we welcome you to today's webinar. It's
Very
a great
nice program,
pleasure
Shobha.
to have you here.
Yeah. We're always proud of you, Shobha. Yeah.
Thank you so much, madam. You're an inspiration, madam. Hello. Arun? Arun, please play the CV. Dr. Hema is a member of Safe Motherhood Committee from Haveri. Hema, please introduce Dr. Rajashri Paladi, madam.
Good evening. Good evening, everybody. It's a privilege to introduce Dr. Rajashri Paladi. Madam is Honorable Secretary of Karnataka Ksoga. She's the Dean of KBN.
Hema?
Yes, ma'am, I'm there.
Okay.
Madam is a member of Academic Council of KBN University, and she's the professor in Department of OBGY in Kalburgi Medical College, and she's a teacher for postgraduate and undergraduate students in various universities. She has presented many papers and guest lectures at various forums. She's a director and consultant of OBGY, Aditya Multispecialty Hospital, Kalburgi. She's a gold medalist in OBGY, and she's a team member representing Rotary International from India to Australia. And Madam has the secretary of the 25th Ksoga conference, which is held in Gulbarga. And Madam is a past president of Gulbarga OBGY Society. Under Madam's leadership, a lot of visitor programs were conducted, which were very helpful for people who are in periphery, especially periphery. And Vistrit has caused a lot of changes in the way we are handling our patients and way our staff are handling the patients. Without us also, they're able to manage it very nicely. It's a privilege to introduce Madam to the
Thank you, Hema. Arun? Shobha Madam CV. Rajashri Madam? Rajashri Madam?
I think she's lost her connection. I think one of you should read it.
Yes, madam. I'm just calling madam once.
She was there all this while?
Yeah. Yes, madam. So today, our first speaker for today's session is Dr. Shobha Gudi Madam. Madam is a very well-known figure in Ksoga. She is a great and great speaker who makes any topic interesting. Madam is MD DNB. She is HOD of St. Philomena's Hospital, Bangalore, postgraduate teacher and examiner, chairperson of Family Welfare Committee, Foxy from 19 to 22, and she did a wonderful job in her tenure. And she was president BSOG from 2018 to 19. Assessor of Government of India Project Lakshya, board member FPAI, peer reviewer for many journals, president of BMS from 22-23, chairperson of Contraception and Reproductive Health, EC member Ksoga. She has edited many books and she has given many talks.
Thanks a lot.
And
Thank
Madam
you, dear.
is talking on a very important topic of how to strategies to reduce cesarean rate. Madam, we welcome you all.
Thank you very much. And at the outset, let me place on record my absolute sense of gratitude and privilege that I share with all of you, that I am being given a platform to speak on Ksoga. Also, I acknowledge the presence of all senior Ksoga leaders, the newly elected president, dear Bharti, and the president-elect Durgadas, also a very good friend, the immediate past president, very dear friend Vidya Tobbi, the treasurer Suman Gaddi, and of course Rajashri Paladi, who I think I would have loved to be introduced by her, but then thank you, Shobha, for that kind introduction. I am also very happy today to see Preeti here. It's wonderful connecting with Preeti. Every time I meet, I think there is some kind of energy infusion which happens. And I'm so happy, Preeti, to see you today. And thank you for promising involvement of Ksoga going forward. And I must assure you, just like Bharti did, that absolutely Ksoga is committed. And actually, Ksoga, everything is in place, like the minds, the willpower, everything is in place. All they are waiting for is a structured opportunity. And I'm sure that you will provide that and we will give you the data. And I think everything is in place for you in the South, especially in Karnataka. So we will join hands with you, Preeti. And with that, let me share the screen. I'm very grateful for all the seniors in Ksoga who have encouraged me, Dr. M.G. Hiramat, my dear friend Kasturi Donimat, Shobna Patel, and Nagaraj sir. I am really missing you today. I don't know whether you have joined. My namaskar to you. And
Sir is there, I think.
Namaskar, sir. and of course, all the past presidents of Ksoga. I'm very grateful that you have always been encouraging, including Dr. Basavaraj Sajan. So with that, let me just share my screen, and I will try to be as crisp as possible because this is a little vast topic, and we look forward to a great deal of more improvisation in our audit, our techniques for dealing with this problem. Is my screen visible, Shobha?
Yes, madam, it's visible, but it's not
Okay.
a full screen.
Now is it okay? Is it
Yes.
okay? All right. All right. So quickly going to the subject, it is indeed, cesarean section is indeed the most commonly performed obstetric operation worldwide. And apart from episiotomy, of course, which I feel is now becoming less because of the selective nature it has taken. Cesarean section rate has been rising over the last 5 decades. All of us know that. And it has risen from something unbelievable 5% in 1940 to 15% in between. And now it is it is always wanted to be, WHO always wants it to be between 10 and 15%. But I feel that it is 4 to 5 times that figure. And during the last 2 decades, the dramatic rise is a minimum of 30% in most institutions is what I look at. In our institution also, it is between 30 and 40%. Many factors are contributing. And the question is, how much is it now? And going forward, we'll try to answer some of this. As a mode of delivery, it is a surgical procedure that can effectively prevent. We all know that it has a saving kind of profile. It has got a life-saving role whenever it is indicated. Maternal and newborn mortality can be reduced when it is medically indicated. So there is no evidence showing the benefits when not indicated. So indication for the surgery should be sacrosanct. As with any surgery, it is associated with short and long-term risks, which is poorly understood by women and by the care providers as well. Risks are higher where there is limited access to comprehensive obstetric care. So please believe me when I say that, the antenatal care, the prenatal care, the preconceptional and the postpartum care has to be absolutely standardized in order to reduce cesarean section rates and also to care for women who have undergone cesarean section rates. So the presence of indication is sacrosanct, I repeat, and we should not perform it in its absence and do not deny it when the indication is present. So every effort should be made to provide sections to women in need rather than striving to achieve a specific rate. That is what we must take home always, that we must provide it when it is needed, but never chase a particular cesarean section rate for institution, because if you stick to the indications, automatically the rates will be very reasonably stabilized and very reasonably controlled. So these are some world statistics on how the escalation of the incidences happened. And you can see that Asia is very much there, though it is a little less than the Latin America and North America, but the optimal section rate is actually unknown. But it is well understood now that it will vary between facilities because of the differences in the obstetric populations. So government and clinicians always express concern about the rise in number of births and the potential negative consequences for maternal and infant health, but have very poor understanding of how to go about it. So it is actually the responsibility of organizations like FOXY and Ksoga to see to it that care providers and the women population understand what is optimal cesarean section rate or why it should be optimized. It is the rate that minimizes maternal neonatal morbidity mortality coupled with maximal maternal satisfaction. And in this era of respectful maternity care, that is of utmost importance. So provide her a care in childbirth which makes her feel worthwhile. It makes her feel complete as a mother. This rate is not known. This optimal rate is not known and varies by patient population. Rates below 15 to 20% have been associated with increased maternal or perinatal morbidity. Therefore, kindly maintain these rates in this era of high-risk pregnancy. When determining birth rates, it's useful to calculate the rate in groups of similar risk using a system like Robson's classification. So Robson's classification is a tool, validated tool for audit of cesarean section as well as cesarean section rate. It is also a very useful tool to improvise in this field and to see which group requires intervention, thereby trying to bring down the cesarean section rate in that particular high-risk group. So to begin with, one must know the cesarean section rate prevalent in our own obstetric unit. That will be the beginning. And this is what we did. There was a time when the section rate started becoming very high, close to 50%. And we assigned this thesis to one of our postgraduates. And it was a study setting in our hospital, 1 year, and all pregnant women who got admitted to the delivering unit. And we classified them according to Robson's criteria. And we saw to it that we put them in one of the categories which is defined, 10 categories which is defined by Robson. And that is how we went about it. These are the groups for the audience to take you through every sentence of the group is not possible. Group 1 is nullipara. Group 2, nullipara, single cephalic, 37 plus, induced or cesarean section before labor for some reason. Group 3 is multi, 37 spontaneous. Group 4 is multi, cephalic, 37 induced or cesarean. So group 2 and group 4 are similar except for parity. And then begins the previous cesarean with labor, induced or before labor, and group 6 are breech, and group 7 is multi-para breech, and then group 8 is all multiple pregnancies, and group 9 is lies, abnormal lies, and group 10 is all single, the preterm, right, including the previous cesarean. So when we classify women according to this, some limitations will always emerge, because some of you might say that this does not allow analysis of cesarean section by demand, okay, or indication and method for induction of labor is not included. So how can you say that this audit is okay? Then you will say degree of prematurity is not included. Then you might even say that inability of the classification to evaluate relationship between CS group rates and outcome of maternal. Where is the outcome variable? But it is not categorized here. And how do you say that this is an audit? So this is an audit which is validated across the globe because many units have utilized, and they have used it rather as a problem solving tool to find out where we are going wrong. Why is it high? So for example, this study in Kerala, they found that the contribution is like this. They found that reducing primary cesarean section is essential. Adequate counseling for VBAC is lacking. Changing the norm for dystocia, that means non-progress of labor, on non-reassuring fetal status should be there. Means we must change our diagnosis here and make it more friendly for vaginal birth. Training and encouraging obstetricians to perform version when it is not contraindicated. That is of utmost value to reduce the section in the breech segment and can reduce the contribution of Robson's group towards absolute cesarean section rates. All these interventions. So this study setting, as I said, in our hospital, I will not dwell on the details of the study, but we found that it is easy to implement. We found that it is a tool for ongoing surveillance and internal as well as an external audit, because if somebody comes to do an external audit, you can well present this and say, and they will accept it as one of the, as a kind of with high degree of credibility. The results can be compared from other hospitals. All authorities can use as part of quality improvement initiative. It is suggested that this can be introduced as a routine tool, and we are using it right now. Common classification, because this is, all these groups are mutually, exclusive. So it allows the evaluation and comparison of these groups and the determination of the most important contributor for cesarean. It guides the healthcare providers about where to focus, so that you can, in the next round of audit, you emerge a winner. So this is how the data were kind of assigned to these kind of tables. All right. So as I said, I will not go into the details. So this was our analysis, 773 and 783, the number of deliveries were placed like this in the birthing thing, and this is what we found. So if you see the red sticks, then you will see that the nulliparous more than 37 weeks, when they were induced, there was a higher rate of cesarean section. Okay. Then even before labor, there were some indications, and that must have been, because of some indication like preeclampsia, etc. Previous cesarean, more than 37 weeks, very high. Nulliparous breech, very high. and then multiparous breech, including previous cesarean, very high. And this is how we found our groups. And this is how we tabled them. And we were able to then identify that we need to have a very stringent indication for induction of labor, and we need to find out ways and means to reduce the cause or indication as a failed induction for cesarean. And that is what we have been doing. Is there any limitation to this? The indication is not included. I think some of this discussion has already happened in the previous second or third slide. The indication for induction is not included. Level of prematurity, plan of delivery with a uterine scar is not clear, and the direct measurement of repeat CS is also not possible. So some limitations will always be there. So if we go on nitpicking like that, I don't think we'll get any perfect tool. So we have to make do with this, and it works for us. All right. So changes in obstetrics, some more reasons for cesarean is what we are looking at now in the Indian context. There is an increase in maternal age. All of us know that, and pre-pregnancy BMI. So obesity is also a contributing factor. Changes in obstetric practice. More use of electronic fetal monitoring. Higher use of the EFM, but lesser understanding, right? And pressing the trigger too often for fetal distress, which is not true, which is not credible. Induction of labor has increased. Epidural anesthesia has been listed as a cause, but it will become a cause if we allow it to become a cause. Reduced use of the mid-cavity forceps, this I agree. Most of us feel it is not safe, so it's acceptable. On-demand cesarean, this is again where counseling plays a role. And then there is one factor where we need to stay strong, and that is fear of litigation amongst the caregivers. That is what creates panic. So pre-labor cesarean, some indications are there, and these are indications where very little can be done to reduce the section rate. So all of us know this, previous surgeries, a lot of tumor like myoma or genuine indications which have been listed, but one of them where we can help with cesarean section on demand. So what are the selected clinical strategies for reducing cesarean section rates in obstetric units functioning correctly? And in them, we must know the cesarean birth, the trends which are happening in the obstetric unit, and with that we can try to target. Avoid excessive gestational fetal gain can be one strategy. Optimal use of cervical rightening agent before induction of labor. That means before augmentation, means for induction you use better ripening agents. Antenatal external cephalic version of non-cephalic presentations. Give more trial for, cephalic, non-cephalic diamniotic twins. This is what we have been doing with good success. Induction at 39 weeks, it seems this has twofold purpose. One, improves the vaginal birth rate because it reduces meconium staining, etc. And secondly, it also reduces the stillbirth rate. Slow but persistent progress. Avoidance of cesarean births in the latent phase or first stage. So allow progress to happen. We'll come to that in LCG. That includes second stage. Amnio infusion to resolve some kind of fetal heart rate deceleration. Well, that is very institution specific. Use of fetal scalp stimulation. That is again, to assess the fetus with abnormal FHR. This is what we do. Even digital stimulation is quite good. Avoidance of delayed pushing. This is one of the LCG guideline interventions that don't allow women to delay in pushing. Encourage them for early pushing when there is a sense it achieves better birthing rate. Manual rotation for second stage dystocia from malposition. So the days of forceps rotation are not there, but manual rotation is possible. Forceps or vacuum assisted vaginal birth for second stage arrest in appropriately selected patients. That means increase your instrumental delivery rate and collaborative midwifery laborist model of care. So this is known as, it is called MDLR. It is the upcoming thought, and many thought leaders, obstetric thought leaders in the world are coming up with ideas for collaboration between midwifery and obstetricians. So I think it is a very strong way forward. Reasons why women want cesarean. They feel it is scheduled, so easy. The fear of pain, previous poor labor experiences, if an IGCA was not good, concern about trauma, pelvic organ prolapse, concern about risk of emergency cesarean, that now it is okay, you're saying I will deliver, but what about 4 hours later, then you'll rush me? Or operation vaginal delivery, because that will mess up the lower genital tract. And then there is a sense of control when cesarean is happening. That is a very pseudo sense, I must say. because there's so many risk factors involved, which they feel is not there while vaginal birthing. Nature takes over there more. A patient's statement during a case conference is, I feel like there's a lot more that can go wrong in a natural birth for the baby than in the cesarean section. And that's why she's opting. So I mean that, this kind of thought is what we have to fight against. So counseling, who must do and who has adequate time, should be sorted out by the obstetric unit. So these are few non-clinical interventions which WHO recommends to reduce unnecessary cesarean sections. Can you see the title there? It says that unnecessary cesarean. So how should cesarean birth rates be measured and what is optimal? What WHO says that we must account for patient characteristics and risk factors for maternal and perinatal outcomes. It should always be outcome related, and Robson's criteria will allow within group comparisons and between group comparisons. So it will help us to target strategies to reduce unnecessary rise, achieve the lowest morbidity, mortality possible, coupled with highest maternal satisfaction, which I have already said. And WHO labor care guideline allows better practices to be inculcated. So when we talk about outcomes, the critical outcomes is the rate, the trauma to the mother, trauma to the baby, asphyxia, maternal birth experience. Never undervalue this. Never undervalue this, because often we don't even ask the mother in postnatal, how was your birthing experience? So always check on this so that we know that there has been no complete satisfaction. Important outcomes of maternal morbidity, long-term infant outcomes, serious morbidity, long-term maternal outcomes of incontinence, etc., and healthcare resource utilization, that is length of hospital stay, maternal readmission, rehospitalization, and this is higher, much higher in cesarean section than in vaginal birth. Now, non-clinical factors contributing to rising cesarean, okay, because there is an increase in obesity, multiple pregnancy, older women have changed in perspective. They increasingly want to control, to determine how and when a child is born. Care providers have changed. I already said that increasing fear of litigation, organizational, economic, and social factors, which should not come into play, but it is coming into play. So this is a systematic review of quantitative evidence in 2018 with 19 randomized trials for evidence of effectiveness of such interventions, non-clinical interventions, all right? And then it was seen that these are the recommendations which emerged. So without going into detail of each, I will just say that health education for women should be an essential component of antenatal care. We are not talking to our women enough. We are not giving them education on birthing and on antenatal care. Childbirth training workshop, nurse-led applied relaxation training, psychosocial couple-based prevention program, and psychoeducation. These are the interventions which were seen to help. And interventions targeted at women. Women think that learning new information about birth can be empowering. The content of material should not provoke anxiety. It should be consistent with advice from healthcare professionals. Women want emotional support along with communication of facts and figures about birth. Interventions targeted at us, at healthcare professionals. One wonderful concept which has emerged is to take second opinion for cesarean section. And there comes the role of a team working in place in the birthing unit rather than a standalone obstetrician. There is immense strength in working together. So implementation of evidence-based clinical practice guidelines combined with structured mandatory. So this is mandatory, it is not optional. Second opinion for cesarean section is recommended to reduce unnecessary cesarean in settings with adequate resources. And senior clinicians able to provide mandatory second opinion. So this is already happening because we have a unit system for working and the unit chief takes the call, and we always do. But what is absent in this system is a clinical assessment by the senior, because often we check on the phone and we say okay or we say not okay, etc. So there should be a mechanism by which a clinical assessment can be done. It may appear hard, but it can be strived for. So following are components of the CPT, clinical practice guidelines. Okay, mandatory second opinion provided by attending physician before cesarean section. The second opinion person has to be with clinical qualification either equal to or higher than that of the attending physician. In the working in the same hospital in the similar setting. Okay, so these are the prerequisites. Another recommendation is that, audit and timely feedback should be there, and there should be someone who is monitoring the entire process. On-site training should be available, and audit for indication of cesarean birth and feedback should be given. So this is documentation and auditing ourselves and using the proper tool like Robson. Interventions targeted at healthcare professionals, there is no clear consensus. The following are according to systematic review. When the definite clinical indication for cesarean across time, for example, breech, availability and access is not there, with healthcare professionals drawing on different evidence to support their underpinning belief about vaginal birth as normal or as inherently pathological, the extent to which we value lowering cesarean section will come into play. So what I have been trying to tell in this slide, which is a little complex one, is that one gets influenced by fear of blame and the value we attach to personal financial reward and any preference for cesarean as convenient and belief about women, including shift in belief of women's preparedness of labor. So uniformity has to come in our practice. Then all these interpersonal problems will go away. Okay. The intrapartum cesarean sections require a different approach for audit than antepartum cesarean sections. And the sole purpose of reducing section rates, collaborative midwifery obstetrician model of care, if you build up this kind of model of care, the intrapartum cesarean section rates will come down. That is the conviction of several world authorities to reduce the incidence of intrapartum cesarean section, emergency cesarean section, midwifery interventions will help, or collaboration will help. Okay, then we can go forward here. So the newest concept by WHO LCG, even in the pandemic, I think some implementation was possible, and the labor care guideline came into play, and it was seen that it is a simple tool for reducing primary cesarean section rate. It is a tool which is very well applicable to low-risk mothers who get admitted to labor ward for delivery. Okay, and implementing it will not increase the duration of hospital stay or the fetal-maternal complications, but it will reduce the cesarean section rate. So we found that there are some modifiable indications. I think we have done this already. So WHO LCG seems to be the way forward because it insists on healthcare provider training. It insists on the next generation part of that. It looks a little complex, but still it is very feasible. We'll go forward with that. And the impact of this at a tertiary care center, when it was seen, it was seen that it really reduces the cesarean section rate. If we, and they are able to easily follow it. Mainly healthcare professionals, trained nurses also are easily able to follow it. This is the conventional pathogram which we have been using. All of you are familiar with this, and this is the LCG. So there are some differences. The section 1 has more details of the woman. The section 2 again has, it is split into pain relief, whether present or not, etc. Companion, whether present or not, and then the details of the fetus, details of augmentation, etc. So greater detail is there, and there is a lot more input on the supportive care which is given to the woman. Whether the postural care which is given, the presence of companion, etc. The care of the baby also, there is a split about what kind of deceleration is present, what kind of staining of the liquor is present, what is the fetal position, presence or absence of caput molding, etc. All is in greater detail. Other factors also are put here, like the maternal characteristics and the labor progress of cervix and descent as usual. Okay, so the labor care guide creates a positive feedback and decision-making loop as health personnel are encouraged to regularly assess, record, check reference threshold and plan. Assess the well-being of women and baby, document labor observation, check reference threshold, compare labor observations with reference values in the alert column. Okay, and plan, decide whether and what interventions are required in consultation with the woman and document accordingly. So okay, you can see here that the planning is not only by the obstetrician, it includes the woman there. So here, there's a kind of brief here, which is useful to go ahead to learn so that we can quickly wind up this session. WHO labor care guideline, the next generation partogram, the red column is highlighting the alert parameters for each observation. The supportive care, whether there is no companion, no pain relief, no fluid intake, a supine position, this should change into presence of companion, pain relief, plenty of fluid intake, and supine position. So this document and altering position according to the woman's wish. So all this is identified here. Fetal parameters, I've spoken about this. Maternal parameters, I've spoken about this. And then labor progress. So I have something to say about labor progress, that more time is given to the cervical dilatation at each centimeter, not like earlier. So uterine contractions should be ample. They should be between 2 and 5 in 10 minutes, between 20 and 60 seconds, yes. And the alert time threshold in hours for each cervical dilatation, at 5 centimeter, you wait for 6 hours. At 6, you can wait for 5 hours. And this is irrespective of whether she is a multi or a primary. 7 centimeter is 3 hours, 8 centimeter, 2.5 hours you can give her, provided mother and baby are doing well. And 9 hours you can wait for 2 hours. And the second stage parameters remain same as what we have been doing earlier. Without epidural, it is 1 hour for multi, 2 hours for primary. With epidural, it becomes 2 and 3. But the first stage is the major difference. And you can see that you can allow more time, keeping the mother comfortable, monitoring the baby, and seeing that she delivers vaginally. And when the time comes, she should push really well. So that is about the LCG intervention, and I'm happy to say that in our hospital recently the thesis was accepted on LCG care, lasting for a year, and the results will be shared soon. We are going to publish the data, and it shows that there is a decrease in the cesarean section rate where LCG was applied rather than conventional partogram. This was a randomized trial between conventional and LCG. We have found very good results. Shorter duration of labor, without any change in duration of labor, reduced cesarean section rate, and comparable outcomes. So in future, as we go ahead, I think there has been a lot of talk about collecting data. So we should become very smart in collecting data, because India has the highest number of births in the world. And if we do not harness this strength, we will not be able to teach the world what obstetrics can achieve, or what good obstetric care can achieve. So please see that we go forward with very clear thoughts, and we have our research priorities. Multi-site studies should be encouraged. Mixed method studies integrating quantitative and qualitative data should be encouraged. In particular, the guideline development group in LCG emphasized that future intervention trials should be preceded with formative research to define locally relevant determinants of cesarean birth. So I think that is where we must start. We must audit first and find out what are our determinants of cesarean birth. And then we will find a way forward. Future research should focus on the following areas. I have already said multifaceted, and certainty of evidence for cesarean section outcome was low. So we should improvise on the outcome related data. Educational interventions for women, audit and feedback with Robson's, insurance reforms. This is important. Believe me, it is very important. Insurance reforms, equalizing physician fee for vaginal birth and cesarean section, and collaborative midwifery obstetrician model of care. Studies should address both short-term, long-term maternal outcomes and infant outcomes. So to simplify, obstetricians who care must think of following cohorts to work on. This is again about research. These are the cohorts. Reducing cesarean section in primary, reducing pre-labor cesarean section, allow labor to happen as often as possible. Please do not intervene early unless there is a dire emergency. Reducing repeat cesarean in a previous cesarean, improve the VBAC, must always use the Robson's audit criteria process to maintain the continuum, and speak to women about the risks of unnecessary cesarean. But this is not spoken about. This is an unspoken fact. So these are my references, and thank you so very much for the opportunity and for the patience. Thank you. Thank you so much.
Thank you very much, madam. Rajeshri, madam.
Yeah, I must say, Dr. Shobha, that was one of the most beautiful presentation to cut down on the incidence of cesarean sections. And it's the need of the hour that the public, the government, the agencies, even the lawyers nowadays are so very aware that they say that why is it that so many cesareans are happening and why so many litigation and cases against the doctors that we are facing nowadays because of the rise of the incidence of cesarean section. Although we have many reasons to explain for the incidence of cesarean section, but time and again, and I would like to highly congratulate you for the commendable topic taken for the dissertation, that this is how we can sensitize our young minds so that the labor care protocols can be implemented in our labor rooms and then, reinforced upon the entire unit which is working in the labor room, so that it shouldn't be a resort that, okay, there are only two ways with little patients, normal delivery, with no patients, cesarean delivery. That has become the norm nowadays. And wonderful highlight of all the points which you have recommended as given by the guidelines. And although we have been talking about this for past decade now, still we have to see that the results are implemented and are being followed very much. And I think such initiatives taken by the Safe Motherhood Committee, and also to talk more on such platforms, will always, reinforce the concept that although we talk of cesarean as a safe delivery, but it's not all safe, and we are going to change the dynamics of the population. There may be a time wherein, the woman's pelvis may become so narrowed that she don't have space for normal delivery, and that is how it has been projected as the evolution of the mankind, that if cesareans continue to happen, then her entire anatomy is going to change. Thank you so much for selecting such a wonderful topic, and thanks for bringing the highlight points as to how the maternal care guidelines have to be implemented in the labor room. And I think this becomes a very important message for all the professors and teachers and guides in the medical college, that we should consider this as a topic for dissertation for the postgraduate students. Thank you so much. Thanks, Shobha and the Safe Motherhood Committee for giving me this opportunity, and thank you, Bharti ma'am.
Thank you so much, Rajeshri,
Thank
madam,
you
for
very
being here. Thank you, Shobha Goody, madam. It was a wonderful talk. Lots to learn from your talk and lots to implement in our practice also. Now I call upon Dr. Sonia Mandappa, madam, to take over.
I'm there, Shobha, I'm joining. Dr. Shobha,
I'm
there. Yes, Madam Dr. Rajeshri Palladi, we will, as a fraternity, we see to that we will not allow narrowing of pelvis anymore.
Yes.
On the continuing note, with the absence of Dr. Bellad, who is actually our chief guest of today's virtual platform, we will still wait for Sir to log in. Meanwhile, we'll continue with our webinar. And may I now request Dr. Ekta Shetty to introduce our immediate past president, Dr. Vidya Tobi. Dr. Ekta?
Yes, ma'am. Good
Arun,
evening,
please
everyone.
say the CV. Ekta is Safe Motherhood Committee member from Bangalore.
Hello, everyone. Good evening. It's my privilege today to introduce Dr. Vidya Tobi, madam. She is the immediate past president, Ksoga 2024-25. She is president of Ksoga 2023 to 24. She is the ICOG Governing Council member 2023-25. She is a professor and former head of Department OB-GYN AMC Vijaypura, State Advisory PCPNDT Board Karnataka. She is a chairperson of Food, Drugs and Medico-Surgical Equipment Committee FOXY 2018 to 2020. She has got the Best Committee FOXY Award, Dr. Mehru Dara Hansotia 2020. Best Publication FOXY Focus Nutrition Across Ages. FOXY Champion Award in 2019. She has got the ERA Champion Award FOXY. She is a National Corresponding Editor, Jogi 2018 to 21, and reviewer as organizing chairperson of Ksoga 2023. She was the president of Bijapur OB-GYN Society 2009, secretary Bijapur OB-GYN Society in 2007. She has a publication in various books and contributions to FOXY Focus and speaker at national and international conferences. She has many papers at national and international conferences. She has organized various CME workshops and awareness programs. She is the advisory faculty of board Rajiv Gandhi University and Women University, and she has been a postgraduate and undergraduate teacher for more than 30 years. We welcome you, madam.
Thank you, Dr. Ekta, for those kind words. Um, I think Dr. Shobha,
Yes, madam.
our next speaker is very well known to us, and every time Dr. Hema's CV keep on changing. So I would love to welcome Dr. Hema Divakar to the August gathering, and really we are celebrating Safe Motherhood Day, though it is on 11th. We are celebrating little late, but I feel that every day is programmed by our Safe Motherhood Committee, and we all strive hard to save mothers. I congratulate Dr. Bharti Rajshekar, our dynamic team, which work with me also, and I'm a part of Ksoga forever. So we will be working together to this. So can I have the latest CV of Dr. Hema Divakar? Yes, she's our next speaker. We only talk about safe motherhood, but she always walks with the safe motherhood, I must say. And she is talking today something about the digital transformation or digital use or AI use in ensuring safe motherhood. She is at present medical director, Divakar Specialty Hospital in Bangalore, CEO and chairman of Asian Research and Training Institute, and also a division director of PIGO, Well Women Healthcare. PIGO, in KCOG, Karnataka College of ONG, and we have started this KCOG under her guidance, and we are implementing again so many programs under her. President Karnataka AHPI, which is the Association of Healthcare Providers India, State Representative of HSSC Karnataka, Chair Nutrition and Breastfeeding Committee Suffolk, ex-chair of a woman healthcare president of DIPSI, and past president of Ksoga as well, and an advocate for delivering quality healthcare. Convener Manyata, and Manyata just completed 100 institutes in Karnataka, and slowly it is moving ahead. We want to sensitize all the zones and all the practitioners in Karnataka, and let us move ahead. An opinion leader and an influencer for social and legal issues which are relating to the women health. She has got many awards and recognitions like PIGO Woman Achiever Award, CME Excellence Award for Artists, and many awards. I must say, I have gone to her nursing home. It is full of awards only in one room. So over to Dr. Hema for her excellent talk. We are going to listen to it and let us implement some of them. And I'm really thankful to her for launching Swasthya Sakhi, which was launched during my Ksoga conference recently. Thank you, Hema, very much for that. And over to her for her talk. Thank you.
ಥ್ಯಾಂಕ್ ಯು ವಿದ್ಯಾ. ಎಲ್ಲರಿಗೂ ನಮಸ್ಕಾರ ಹಾಗೂ ಯುಗಾದಿ ಹಬ್ಬದ ಹರುಷದ ಹೊನಲಲ್ಲಿ ಎಲ್ಲರಿಗೂ ಶುಭಾಶಯಗಳು. First of all, I must acknowledge and place on records Safe Motherhood Committee chaired by Shobha Shaibi. Hats off to her for her patience. Many phone calls which I did not pick up. Many messages which I did not respond to. Many times the dates got changed and the time also got changed. But the persistence and consistency of Shobha, I said, today is a mad day for me, but still I will come and I'll speak in this program. Thank you, Shobha, for getting me on here with my very beloved friends. Yugadi marks new beginnings, and at Ksoga, we've had Dr. Bharti Rajshekar take over as the president at the helm of affairs to take Ksoga to newer heights. And in the frame, I see Dr. Preeti and her posture. Sometimes she will lean back on her chair. Sometimes she'll be at the edge of her chair. It is very symbolic of the fact that Dr. Vidya Tobi and Rajeshri Palani leaning back and basking on the glory of how much they have done for Ksoga in the last year. And that's how Preeti has also, as the National Safe Motherhood Committee, set an example, task shifting to the next generation. Many initiatives inclusive of Vistrut and Jeevan Dhara, which have really flown across the borders to Suffolk regions as well. And still she's at the edge of the chair because things are not complete yet. There's a lot more to do and a lot more to go. And that's how we have roped in people like Sonia Mandappa into newer organizations of Association of Healthcare Providers of India, where we want to provide skilled providers, because everybody just coming with a certificate, no good. They need to be skilled, and that skill transfer has to happen in a practical, sensible, pragmatic, doable way. That is the digital skill transfer. And that's what my topic is for today. Sonia is also a key member, along with Vidya Tobi and Bharti Rajshekar, Jyoti and others, for the HSSC, which is Health Sector Skill Council. If you go to the Skill India portal and see the health sector segment, one sanitary inspector, one laboratory assistant, some meager courses here and there. Now what we're trying to do is to create many courses which are short, smart, can be transferred digitally, get moving with the providers who are the front line, and exactly what Dr. Goody spoke about, how to implement an array of things that the WHO or the world global leaders have suggested. I can see Suman Gaddi with the name of Someshwar Gaddi on the screen as well, because in the hand wash, Suman K, we tell G for Gaddi, which is the watch, that her name is included in our acronym by default, and Dr. Durga Das, whose enthusiasm propelled the first set of pilot initiatives of Manyata in Karnataka, and his bunch of staff nurses have also taken individual certification for assistant to maternal newborn care, which is yet again a new cadre of upskilled nurses within the system who will scale up the quality initiative, delivering the best that they could do for every girl, every woman, everywhere. Sonia, I had just messaged that he has unmuted, but he has not allowed me screen share the AV guy. That's it. Host disabled participant screen sharing.
Arun sir?
Arun, please.
Thank you, Hema, for that very, what do I say, enlightening opening remarks before you start the actual movie. It was just the trailer.
But you know, just like Jamkhandi, somebody is speaking.
Sir, can you mute the other participants?
See, there is so much happening. Ksoga. Okay. As I said, continuum of care, so very important, from Dr. Tobi to Dr. Bharti Rajshekar. There's Rajeshri Palladi continuing the care as the secretary of Ksoga. Constantly, the Ksoga team is at it, doing their best that they could every single month, every single week, every single year, scaling up the talents from within the state, which is, in comparison to other South Indian states, not very far behind, but not leading in the forefront as well. So we need to run the race fast and not compromising on the quality. Sonia, can you just make sure, Shobha, that the slides are seen?
Yes, seen, madam.
Yes. So saving lives, now as a division director of FIGO Well Women Healthcare, we believe that it's a life cycle or the life course approach, and readiness is the key. Adolescent to be made ready for reproductive age group, reproductive to be made ready for aging gracefully, so on and so forth. And when we reflect on the fact, why are we saving lives today? It is yesterday's problem. Helping mothers survive, helping babies breathe, etc., etc. We should have done it long ago, but now we are on a fast track on that. But recently we had a national summit on cervical cancer, which only brings to light that these mothers with the Safe Motherhood Committee, whose lives we are celebrating today, should not progress another 2 decades later to something that will mar the quality of their lives, like diabetes in pregnancy, going on to type 2, hypertensive disorders in pregnancy, going on to cardiovascular disorders, missed opportunities for cervical cancer screening and vaccination, going to cervical cancer and losing lives. So we need to pay attention right across and not miss any opportunity to do better than the best for everyone who steps into the doorstep of any healthcare providers. And that is why the Swasthya Sakhi program, which Dr. Toby mentioned, is that anybody and everybody should be able to create a buzz about wellness. You know, this pregnant women, just one antenatal visit. Now we have come a long way, 10 visits, but 4 may be physical and 6 may be digital. The hybrid model, which we have adopted for our continuing medical education programs, also is seeping into the world of medical practice. Hemoglobin tested 3 times, but not corrected. Simply talking about Anemia Mukta Bharat. And after we've initiated the course, believe me, every ASHA worker, every frontline worker who has taken the course has recognized why it's not only important to test, but it's also important to treat and talk about it. The sugars, one question that all our Manyata nurses fail in the first module is fasting, non-fasting, 75, 100, 1 hour, 2 hour. The single question where from 20% of the pre-test, it scales up to 93% is on the sugar test. Then there are other issues where this does not come for check, and then issues like polyhydramnios, etc., preterm labor. The staff is unaware of active management of third stage. And believe me, the pre-test in the Manyata program, which we started in 2013, we assessed the scores of all the 16 standards, which we had laid out, and scores of 70, 80% in complications management. That was the biggest score that the setup achieved. Why? Because the consultant is in the picture by that time. You mess up, goof up initially, not doing the things that you ought to do, and that proven very costly. Patients land up in complications. Then the specialist steps in. Then heroically, everything is managed. And therefore, the reflection that the basic things, the primary care, the evidence-based, the must-do, it has to be inculcated, and the skills have to be transferred right into not only the skulls, but the hands of the performers at the front line. And that we as champions across the country, both as master trainers and as assessors, are witnessing the progress of the gap narrowing down between knowing and doing. It's not just enough if you know, you have to do. So that is what we are embarking on. And when we say readiness, the women and families also have to be ready. Plenty of scope now with the social media and the awareness creation. The infrastructure, actually the least expensive is the OBGYN setup infrastructure, which everybody should gear up. There are certain issues in infection control, etc., which we found in smaller places, which can easily be corrected. And the key recognition that frontline providers are indeed our soldiers who will perform their duties to the best possible extent, so that to scale, the quality improves. And by their readiness, there was a recent meeting where the head of one of the smaller nursing homes said, 20 years, this staff has been working with me, and she used to just stand there like a dumb thing. And then when I scold her, when I push her to do things, she used to get. But now, just with a slight change of expression in my face, she can identify that this patient is in trouble, the bleeding is a little more, and she must do this, that, and like a team lead, she's instructing every other member. That is a sea change in the attitude and culture. So when we say readiness, if it is anemia, Anemia Mukta Bharat, the guidelines, there was a national level technical meet even last week. Everybody's talking about pregnancy, pregnancy, pregnancy. But that is a quick fix method. Pre-pregnancy care. What were you doing before she embarked into the pregnancy? What were you doing between her first pregnancy and the second pregnancy? That's a question that we have to ask ourselves. And it's not only that the correction of anemia is needed for saving her life at labor, but also the new protocols, the new amendment which is going to come in the Anemia Mukta Bharat is she must be in the pink of her health before the pregnancy for sure. If not, at least by mid-pregnancy, so that the transfer of iron from the mother to the fetus and the brain development goes a long way in improving the health of generation next. There are lots of factors which can be checked prior to her embarking on the labor. The risk factors, the previous PPH, previous C-section, hereditary coagulopathies, what is the position of the placenta, which is identified through the pregnancy, and the institution where she has to deliver, that is guided. That is the readiness. And closer to term, what are the other comorbid complications? And at delivery, what will you be ready with? So preparing the women throughout not only her life course, but also in her journey before and beyond pregnancy is really, really a must. So our organization, Asian Research and Training Institute of Skill Transfer, is determined. It's on a mission mode to make things happen in bridging the skill gap, and the vision is to skill India. Always we have been boasting of 30 million deliveries in the country, but are there at least 1 million frontline healthcare providers who can do justice to the 30 million women who deliver? And I don't think the answer is positive yet, but we are well on our way and are champions, not only in Karnataka, but beyond. Also, they are very, very passionately synergizing our efforts and activities to do more than what we've done before. So understanding the less understood was also another series run by FIGO. And they think that India is a great role model because despite all the constraints, somehow in the Jugaad way, we have managed to move things ahead and we are doing better than many other countries. That doesn't make us complacent, but it only inspires us to do more because we are moving in the right direction. So Manyata, the program which the leaders within Karnataka are also trying to fast track. Tamil Nadu, every year they do at least 100 private centers certified by the Manyata. Pan India, our own organization has done more than 700 centers, but overall the Foxy has done about 3,400 centers, and the takers are onboarding for Manyata. Not only that, and recertification also, they're coming back for refresher training where we are adding on skill lactation assistant course, for example, childbirth planning, which Shobha talked about, mental health, nutrition, all these small courses are being added on to make it more effective because enough is not enough. You will see here how we have transgressed from, this was the Karnataka team who came into our hospital in Bangalore to take the master training, which was done in person, physically, with all the stations being created for demonstrating the skills. But as how slowly we moved ahead, we recognized that to reach the last mile, we need the help of the technology, and collaborating for capacity building has been our passion area to make the childbirth safer. And I encourage each one of you, from even the smaller places, they're doing such a good job with their commitment. And, some of the teams from Kalburgi and all, even the hand wash, they have made very nice, cute little videos with the scroll, with the music, which we showcase very proudly to the rest of the country, that if there is a will, there is a way, and how they move ahead. And I think there were 4 ward boys kind of stuff who bought different colored bio-waste disposal, different colored bins. And I will share the 1-minute video within the group where what has to go into which colored bin, and each one comes, puts it in colors. It's just their way of, doing things. So sometimes when these little bit of offbeat funny videos are shown, it sticks more in their heads. And the whole intent is make it fun, make it learning, and make it unforgettable so that they will keep to it. So as we said, that 16 clinical standards, which have now been upgraded to 20 standards, and the 10 facility standards right across the country, making things better and safer. And readiness, recognition, response, and reporting. Data capture also has been very well instilled into the staff. And even, PPH and preeclampsia, which are the forerunners, the pre-test and post-test, within a week, there is a huge difference in their understanding, even the nuances of it. And we have recognized that 50% of the hospitals do not have protocols or risk assessment and the drills and the ways of measuring the blood loss, etc. We've taken a testimonial from many of the staffs who are working there for 20 years, 30 years, saying that we never had a single training program ever. So that speaks volumes of the fact how much reassurance, how much hand-holding, how much confidence they would need from us. Here you would see the specifically to the PPH issues, how the adherence by the various hospitals started evolving and increasing prior to the coaching and after the coaching, and the feedback was that the level of their confidence had boosted, and not that they did not know the theory, but they couldn't actually imply it in their implement it in their practice. The in-depth knowledge and the skills in handling eclamptic patients, then resuscitating the newborn, because the first answer they always give, "Illa madam, pediatrician bartare." That's the, and they have now recognized the value of that one golden minute. Okay, and when Sonia and others take the class, they're very excited to actually follow that in practice and principle, and they're proud that they have, the babies who don't breathe, who have not cried in the first few seconds. They are proud of how they have managed it and saved lives. And the point about Robson's classification, some of the staff nurses say, my madam doesn't know about it, but we are documenting the Robson's classification because there were many consultants who have not paid attention to that yet, but in very small nursing homes, whether it is Athani or Gadag or any corporate, they very promptly, very religiously write it. And 3-monthly audit gives us great insights as to the greatest segments being the ones with classification number 5, that's previous section, and preterm, maybe even iatrogenic, but then those two are the largest groups and comorbidities which have prompted them for an elective section rather than giving them a trial. So this is what a general, the sequence goes. But I must underscore and emphasize and say, we thought nobody will be interested in plotting the partogram, but our master trainers will stand a testimony to it, how well they're plotting now, how much they've recognized the importance. So every supervised delivery gets you closer to a normal vaginal delivery, because nobody has seen, nobody has monitored. You're likely to get stuck with more complications, and you may have to take an emergency decision. So the capacity building with a variety of language-based skill training has been the strength of these simple evidence-based initiatives. And we have written out several papers, both qualitative, quantitative, as the research initiatives that were mentioned, the case reports in international journals, where strengthening the quality of care for safe delivery, of empowering the frontline healthcare providers. It's a mindset of the consultants also, which has to change a little bit, because they think that they have to be there to do it all, which is not practical and impossible. And there are some key parameters, whether it's GDM testing, anemia check and treatment, respectful care. Preeti and others will watch for this, that there is a lot of communication skills which have been instilled in the group of Manyata trained nurses. The PPH prevention by just doing the active management of third stage of labor, pre-eclampsia, eclampsia, timely initiation and transfers after the magnesium sulfate, whose doses they know very well, plotting the partogram. These are some of the key things which have made a world of difference. And one more study that we did on 4 important parameters: glucose testing, Amstel, diazepam, whether it's the first choice, plotting of the partogram, when it should be started. You will see Bihar, Tamil Nadu, Punjab, Maharashtra. These 4 states we assessed. And because the single step originated from Tamil Nadu, pre-test scores were 60. But 60 not good enough. It scaled up to 100% after the training. But places like Bihar, Punjab, you see only 16% were doing this test. They scaled up to 89%, 69%, which is a huge jump. Maharashtra also half and half, 40%. That means half the women were not even tested, but it went to about 90%. Similarly, understanding that diazepam is not the drug of choice. Again, you will see similarly a huge surge in the understanding and clarity in the fact that no, that's not the first choice. It is the magnesium sulfate. Even magnesium sulfate, if you see the international publications in the low middle income countries, the lack of confidence and the provider competence is the single most barrier for instituting the loading dose of magnesium sulfate. And Sonia will know that we always teach them that it's 14, so they have to give 5 in each buttock and 4 as IV. So this is the thing which they remember like little children. You know, we teach them and they do, and it's, as I said, it's good fun, but it has a very serious purpose onto it. And still, that is the active management of the stage of labor. Again, the 4 states, you will see that doing it within 1 minute after delivery, OCM, all the 3 steps, has doubled in its performance, which again will translate into the better outcomes in terms of PPH and saving lives. Plotting the partogram, every center is gaining a little more responsibility in supervising and plotting. So upskilling definitely improves the outcomes, and you will see the research results for all these 4 standards combined together. Anywhere from 40, it's gone to 80. That means it is of a significant value, doubling up so it is an evidence-based work which we have projected globally, and all the South Asian regions and the African regions also want to take this program. So from local to global, we are very proud to showcase such a simple program, but it's very practical, doable. First things first, even in diabetes, we had said, Pehla kadam, Arey Baba, at least test, you know, so that got moving ahead. Similarly, the Manyata training has been a real game changer. And as I said, the success of Tamil Nadu batches of it. This is the old slide with 9th batch. Now we have finished 14 batches in Tamil Nadu. They're racing far ahead, and every state leader in Tamil Nadu has taken it upon themselves that they will see to it that they will escalate this program in places like Ramanathapuram, etc. 100% saturation with all the private centers, and no mortalities reported. They were proudly showcasing their data here and there in the Tamil Nadu conferences, at which we are very happy that we were a small part of their journey into wellness and safe motherhood. The e-health, the technology enabled is the future. In many centers within Karnataka, we have already, you know, Shobha and Shaivi and others are already using this. Anita Ki and Pranita Rao, many have taken this, the baby beat or the FetoSense, which is a remote fetal monitoring device, because there are many high-risk pregnancies. The constant monitoring in the end term is also really needed. Point of care devices in our outreach programs, the way we teach them to do the digital BP monitoring or the glucose check and hemoglobin check, not rocket science, simple enough, but they're flagged off at the right time and sent to the centers. So we've also published on the use of baby beat in the high-risk cases, and the challenges of overcoming the traditional in-person prenatal care versus the usability and acceptability of remote monitoring device for the pregnant women in India. So this was also a very well-received study, because it actually showed the cost, the access, the quality improvement, everything that comes with it, how the technology has helped, because this is the reality. As I said, the quality, affordability, access, and the rush that you would see, 2 minutes time that we can give every patient, it's a clear no-no. The demands are also increasing, but we have to plug it in a very different way, because one person who is at the senior level cannot do it all. And millions of mobile phone users, though there is a small grumble and rumble that many rural women do not use the mobiles or do not have their own mobiles, or the husband has to give it. Very quickly, by the time you blink, another 5 years are over. The new generation is now tomorrow's mothers. Each one, the first thing that they'll demand from their parents is that they have to have their mobiles. So the next generation will surely, all the girls and women, girls today, women tomorrow, will have their mobiles. So that is, again, your health is in your hands is our mantra there. And the cost-effective, quality-driven skill transfer modules have come to stay. And the first batch, I'm proud to say that Karnataka did the pilot with the Health Sector Skill Council. You see how they're appearing on the online exam with the same 16 standards. If they score 70 on 100, then you see in the other picture how each nurse is sitting at their system, where on the video, the assessor will assess them for 10 different skills, one-on-one, and they get the certificate called Assistant to Maternal and Newborn Health. And in various parts of Tamil Nadu and Karnataka, about 200 such individual nurses have been trained. They're getting better placements. Maternity centers are eager to grab them because they know the quality of the work that they do. And the salaries are also increasing, which means that the livelihood and empowerment is also increasing. So these are all the variety of things that they learn during the assistant to maternal. And look at the pass percentage. That's because the nurses are very fresh in their mind. There is no unlearning and relearning. They're open to 100% receptivity, which speaks of the 100% pass. And this is how they proudly possess their certificate and have a sense of self-worth. And you see it being distributed at an event with the NABH and HSSC chiefs and the AHPI president as well, which the individual nurses from within Karnataka who have taken this course and who are proudly, as the first batch, having their medals onto themselves. And ASHA workers are not far behind. They are themselves enthusiastic and coming and training with us. And anybody who is receptive to gaining more knowledge, which can be translated into action, is really, really welcome. So in conclusion, the wellness wheel across the lifespan speaks of more work that we have to do beyond the motherhood stage. Motherhood, we have to anyhow make it safe. Shobha Shaivi has no option. We have to make it safe. Okay. Before and beyond, yes, from adolescent to senescence, we are on the move, trying to do different things at different points in time. The future of healthcare of women in India is really through the digital innovations. We are driving it. And when we say readiness is the key, we have to tell ourselves, yes, we are ready to move this movement forward and paying attention to details and trying to do the best that we can through Ksoga and KCOG. Once again, with my huge congratulations to the Safe Motherhood Committee, the conveners, the chairpersons, and the old team which have performed brilliantly last year, and the new team with new hopes. We are waiting to join hands with them. I'm very, very thankful for your kind invitation, and I always love being with my people. Thank you.
Thank you very much, ma'am.
Vidya, madam.
Thank you, Dr. Hema. You're always inspiring us. And as you told, we are ready. And I must say that everybody who has joined should really take it forward and propagate the ideas, not only ideas, the implementing those ideas, and bring all the healthcare workers together and bringing them together, teaching them each one teach one, like that. We have to go ahead and let us make safe motherhood safe. So that is what I want to say, and I'm really proud that I always get inspired by Hema's talks, and I always get new ideas how to implement that. Thank you very much.
Thank you,
Thank you
Madam
so much.
Dr. Vidya Thobe. Yes, Madam Hema Divakar, we are ready. I think in this platform, we always, all of us, take a note that we are ready. But we also know that the capacity to learn is a gift, but the ability to learn is a skill. But the willingness to teach is also a skill. Now, when it is a skill in our fraternity, and it is spoken about the digital skill, it is only Dr. Hema Divakar's vision and commitment. And we follow you. Thanks so much, ma'am, for your wonderful
Bharti wants to say
presentation.
something. Bharti.
Yeah.
Dr.
Yes,
Bharti,
yes. Hema, thank you, and thank you for your best wishes, and of course, the very inspiring messages you have passed. But I think we have to do a lot, even in Ksoga, in spite of all of us doing extremely well in many of the activities. I think in safe motherhood, like we are the north of the south, as you know. So I think we need to seriously audit what is happening and try to get all our healthcare workers skilled and take the training. I think all our Ksoga members have to introspect on this point. Let us gear up, let us train all our staff, and let us see that they can definitely contribute to reducing the maternal and mortality and morbidity, and save all those many women who still persistently happen to lose their lives. So I think much is to be done, Hema, and let us plan out a strategy and get this moving in a faster mode in Karnataka as well as in the other states. Thank you very much for being with us. Thank you.
Can I say something?
Yes, Madam.
Ma'am, always humbled to listen to your talk and your vision, and always inspired by that. Of particular significance would be the way you see as the digital media to take care of the patients who are remotely connected with the cities. In spite of so many connectivity and so much of work going on at the ground level and the government level, still we find that even today, some of the patients, they fail to come for the checkup correctly. And just yesterday, I had a 40-weeker who came with the IUD. So the concept of reinforcing the safe motherhood to the peripheral and the reach out programs, and it would be wonderful if you could give us an insight into which are the areas in Karnataka where we could really take up as an issue. I'm sure Dr. Bharti Madam and myself will be able, more than happy to reach out to such centers wherein the mortality rate continues to be higher, and we would effectively like to work something towards that consolidated. And I think Dr. Durgadas is there, and if all the leaders sit together and make a 5-year plan like the government does, then a 5-year plan in Ksoga would go out in a long way to address this particular issue. Thank you so much, ma'am.
Absolutely. Points well taken, Rajeshri. We have to work from ground upwards. So we are focusing on block level, home to home. The family program which the government is doing through the NCT ministry, where the elderly are getting their BP and sugar check. We are saying, why not add to that Griha Bhagya the adolescent girls and the women of the house to be checked for anemia, BP, sugar, and breast cancer and cervical cancer. So that's an integrated kind of an approach where they can flag, and also this fetal sense, if it's put in their bag, the pregnant women, they can also check the fetal heart. So reaching to their doorstep with the point of care devices has been an inverted vision that we are trying to bring out. So if, as we said, we are all ready, and together we can and we will, which is my very famous, the strong punch that I tell myself every time that I speak to my champions, that yes, we will do it.
Thank you, ma'am. Thank you. Thank you so much.
Such a wonderful note, ma'am, with the icons of Ksoga. Everybody is speaking about women's health and road mapping it. Now, moving on, I now request...
I will tell something.
Yes, Shobha, please.
Thank you, Hema Madam, for being there. It was an honor to have you, and it was such a power-packed and inspiring talk. Definitely, Madam, we will make a Manyata drive through Karnataka this year, because Vidya Madam has been behind us to do that. And we are also planning since many days. So this year, we'll make it a Manyata drive, and we'll need all your support and guidance in that.
Absolutely. Yeah, thank you.
Thank you, Madam.
Thanks so much, Dr. Shobha. May I now request Dr. Josna, who is one of the...
MB Ballat sir has joined.
Oh, that's great. That's great. I've been actually waiting for Dr. Ballat sir. Can we... Yes, sir.
Sorry.
Good evening, sir.
Good evening. Good evening. Sorry.
Good evening. Congratulations, Ballard.
Thank you. Thank you so much. Thank you.
Good evening, sir.
It's all your footsteps, madam. So happy to share that we have completed the rapid iron study, madam. So shortly you will hear the result.
Michael was there in Delhi last week. Michael Auerbach? Yeah.
Yeah. Sorry, I was stuck in one emergency and I came for the class, that's why I couldn't, this class was unscheduled. So I had to be there. Sorry for the late joining to this.
Sooner or later, Ballard has to be there, and you're here. Thank you.
Please welcome. And
yes, sir, but I want to officially welcome you.
So we're really glad to have you, sir.
Yeah.
call upon Dr. Sonia Mandappa madam to introduce Dr. Bellat sir.
So a warm welcome, but then it is the mid segment of the program. We are
I know,
always used
madam.
to we're seeing bladder pulled up till the mid segment, sir. So we are used to it as obstetricians. But then this is a formal introduction for and a welcome note for our
Yes.
this webinar
Yeah.
of Indian College of Obstetrics and Gynecology, one of the pillar of Ksoga, who successfully completed the presidentship in the year 2018 and 19. And I'm sure all of us will agree, Delhi University is blessed to have such a teacher, a guide, mentor for many students, Professor Dr. Mrityunjay Ballat, a Newton Baba awardee, recognized excellent academician, a professor who's a recipient of various national and international awards, and he's an encyclopedia by himself. He himself is principal investigator for international trials. Sir, we actually missed you in your physical presence last Saturday, Sunday at UF Manipal. But
I know.
Understand that you got very busy in your department activities. And I should make a mention here that his department was awarded for highest rare and clinical case presentations and scientific discussions. I'm also happy to share that they're bagging this award on the third consecutive year. Congratulations, sir. Now we can
Thank you.
We can imagine the expertise and mentoring which goes with teaching experience. And if I'm not wrong, I accounted to 24 years, 6 months, and 3 weeks, if I'm not wrong. So, sir is now decorated the president post of KCOG. And it is my distinct pleasure to extend heartfelt congratulations from all of us on taking over the role of president of KCOG, sir. This appointment is a testament to dedication, your expertise, and unwavering commitment in advocating women's health. I must say, Dr. Bellat brings in his role a wealth of experience, leadership, and deep understanding of challenges and opportunities every doctor is facing in our profession today. Sir, we are confident that the association will continue to thrive and make significant strides in the year ahead. And initially, first two speakers did wonderfully well, conveyed their messages, but we missed you on screen. But then we have a long way to go. Over to you and welcome you, sir.
Thank you, Sonia, for that elaborate introduction. I don't know whether I really truly deserve that, but it is indeed a proud privilege and to associate with this webinar. And thanks to Shobha Savi and Sonia for taking this. I think my only few points I want to share in this webinar on the Safe Motherhood program, what is there. See, we have come a long way from 539 deaths per 100,000 in 1990 when I started as a consultant. And today we are well below 70 in Karnataka. In India, we are quite still higher. But it's a great achievement. But yet, we need to achieve more. Why those 70 women also should die in Karnataka or in other places? Because what wrong they have done? Are they wrong by being taking a birth in this place? Because Sweden, and which has the least maternal mortality and the least C-section rate. But I don't want to compare C-section rates of ours with them, because the health status of our pregnant woman differs very much from what the Western world sees. We cannot, universalize, like WHO has said that cannot have more than 15% C-section rate. See the context with which we must see the pregnancy complications in the developing world and developed world. See, anything developing country is when we cannot only say we are developed when we achieve the woman is safe and the children are safe in this country. So till then, we may land in moon also or land on moon, even then we won't be called as a developed world unless woman is safe and the babies are safe in this world. So what we need to do as an obstetrician, I just want to see that we should concentrate more and more on the preconceptional health of a woman. And if one factor which affects the outcome of pregnancy, it is the preconceptional or the health status of optimal health status of a woman when she enters into the pregnancy. So what we have to do, see, there are many opportunities. Many of our obstetricians come across. We always say that she came only after pregnancy. She came in labor. But are we doing for infertility patients? There are certain tests which we can do and we can treat them, or certain conditions for which they come before the pregnancy. So we need to adopt the newer technology of making the woman healthy before she enters into pregnancy. For example, I want to give is, do their iron levels. I'm talking about not iron deficiency anemia. Let us not go from iron deficiency anemia. Iron deficiency anemia is severe spectrum of the iron deficiency. So we need to treat when they are iron deficient. I'm seeing that in many of our own doctors, they are iron deficient. And when you see in the evening tiredness with a pain in the legs, this is a typical symptom of iron deficiency called restless leg syndrome. How many of your mothers, our mothers, or elder sisters, they complain in the evening hours, their chronic leg pain. And this is the typical of iron deficiency. So what we want to see, apart from this, we are seeing of late more hypothyroidism, medical disorders. So anemia, apart from that, not only anemia, iron deficiency we should correct before she is pregnant. Look for her hypothyroidism. Any other medical disorders she had, or is she in a healthy status to become a pregnant woman? See, when we go to the war, pregnancy is worse than a war. So when we go to the war, we prepare and go. Are our women enter the pregnancy in a preparedness? Whether the family is prepared, birth preparedness, these all concepts we should adopt if we want to further reduce the mortality. Now, majority of the mortality is causing conditions to a large extent we are able to control. But there are still factors which we need to adopt in order to achieve the best beyond this. From 69 to come down to below 2025, we need to adopt. And the imaging technology has to be appropriately used, especially early ultrasonography. Though books do not recommend because they look at the outcome. So ultrasound cannot bring you the outcome because you diagnosis of ectopic, diagnosis of cesarean scar pregnancy, the placenta percreta or excreta syndrome, or spectrum disorders, and other conditions can be only diagnosed by proper imaging technology, and it should be adopted in, and not just once, that is first trimester anomaly scan and late in pregnancy. Because if you read the latest article on one of the British journal, it is given that the modified approach to third trimester scan, so which will tell us and when a woman should deliver. And all this has to be planned, and the imaging technology is very, very helpful. Apart from this, we are also trying to look at the advanced technology which will become part of it some or the other time, like they're looking at the how well the placenta is formed by PLGF levels in early pregnancy, and at the occurrence of the hypertension, whether should I continue her pregnancy hypertension with conservative treatment or I should terminate. There is this very simple tool of investigation which is coming in a big way. That is, we are routinely doing that SFIL to PLGF ratio. I don't know how many of you are doing. If the patient with hypertension comes to you, and if you do this, if the SFIL to PLGF ratio is more than 38, that means preeclampsia is diagnosed. And when it is more than 84, this is the patient who needs immediate action. I recently had a 26 weeks pregnancy. We just got it done. She was IVF pregnancy, and her SPIL to PLGF ratio was 516. So if we would have left her, she would have thrown a convulsion or abruption would have happened, or she would have gone into DIC because platelet was already 92. So what we want to do now is, if we want to ensure safe motherhood, our antenatal care must adapt to this. And that is why we should see that we do these technology and the facilities and optimal state of health before the pregnancy to achieve this, because there is a concept which is coming up in a big way. If they are well formed PLGF, if they are not anemic, if they are not hypothyroid patients, should we really have 6 visits or 7, 8 visits as WHO recommends? So please, we need to adapt to the situations. 8 visits, is it really possible for our rural women? On the contrary, you do the PLGF, she is treated with anemia, she is iron need not be given, single dose IV iron can be given. And if we all do this, should we really need 8 visits? So these are the things we should look in the advanced technology, and our safe motherhood should, and ensure the safe delivery. And here, why our cesarean rates are quite high? There are social factors, there are individual women's factors, and there are disease factors. So we need to look at all these angles. Suddenly, we cannot say that we can bring down the cesarean sections. Our approach, the health status, hospital facilities, all these govern the management of this. So I just want to say that we have achieved a lot, but we need to achieve more. And for this, our care and the practice and the way we look at the pregnancy and pregnant woman prior, during, and at labor and postpartum should change. And if we want to bring this, I think Ksoga Safe Motherhood Committee should adopt newer technology and how we can do or achieve this healthy pregnancy and a healthy woman, or the what we can say at the end of every pregnancy. Every wanted pregnancy should culminate in a healthy baby to a healthy mother. So that's what we want to ensure in safe motherhood. So I once again thank, and this is the message I wanted to give. So please provide advanced care to your pregnant woman, and see that once we have these levels or the cost of these investigations come down, probably this will change the whole scenario of our antenatal care practice. Thank you very much once again.
Thank you, sir.
Thank you. Thank you very much, sir. Sir, indeed, the vision is already set, and it's only that you being a torchbearer, we will follow your footsteps. I think sir was traveling. I think we got disconnected also. And moving on, I now request Dr. Josna. Josna has been representing Safe Motherhood Committee, Mangalore. Dr. Josna, are you there?
Yeah, she's there, madam. Yeah, she's there.
I request you to kindly introduce our EC member. Name suggests it's all. Shanta Swarupi, Dr. Shanta Shekharam.
It is indeed an honor to listen to all the stalwart speakers till now. It was and to listen to the honorary work what they are doing. It is indeed a privilege to welcome Dr. Shanta Shekhar ma'am, who is presently heading the Shanta Nursing Home in Shumaga. She's also was the organizing secretary in Ksoga 2017. Presently the EC member of Southwest Ksoga. Her special field of interest are infertility, high-risk pregnancy, and ultrasonography. Over to you, ma'am. We welcome you, ma'am.
Shanta, madam.
Good evening, all. Yes. Good evening, all.
Good evening, madam.
Am I audible?
Yes, madam.
Yes, madam. You're audible.
It gives me great pleasure to introduce another speaker, Professor Dr. K.M. Babu. Hello.
Yes, madam.
Am I audible? Yeah.
You are audible, madam.
Okay.
you're audible.
To welcome and introduce Dr. Professor K.M. Babu, consultant at Caritas Hospital, Kottayam. Doctor is going to speak to us on cesarean techniques, what we are going to adopt. To introduce Dr. Professor K.M. Babu to this august audience, he is an alumnus of TD Government Medical College, Allappi, Kerala. He was commissioned in Indian Air Force in 1988, did his post-graduation from prestigious Armed Forces Medical College, Pune. He is a diplomat of National Board and member of National Academy of Medical Sciences. He served in Indian Air Force for 30 years as a gynecologist. He has been an HOD of obstetrics and gynecology at Command Hospital, Air Force, Bangalore, and professor in Rajiv Gandhi University. He has been awarded Best Referee Award for Medical Journal of Armed Forces of India in 2007. There are many national and international publications to his credit, and he has got several patents. His field of interest is innovations and inventions. Now I present to you Professor Dr. K.M. Babu to this august audience. He is going to speak to us on cesarean techniques, what to adapt. Over to you, sir.
Good evening, everyone. Am I audible?
Yes, sir. You are audible, sir.
Yes, sir. You're
Yeah.
audible.
Thank you so much for this kind introduction. At the very outset, I would like to thank the organizers of this webinar profusely for giving me this opportunity. And I also congratulate the new office bearers of Ksoga. And I feel humbled and honored to be present in this audience, being the first, being invited as a speaker of the first webinar. Thank you so much. And my previous speakers have spoken about the safe motherhood and reducing the rates of cesarean section. Though my topic is also technique of cesarean section, that also indirectly aiming at the safe motherhood and reducing the rate of cesarean section. Can I have my slides, please?
Arun?
Yes, madam.
Yeah. Please help me in sharing the slides. My slides are visible?
Yes, sir. It is visible, but you have to make it full screen, sir.
Oh. I will put in the full screen. Can you load the slide which is given there, please? Yes,
Madam, do you have slides?
One ನಿಮಿಷ Arun. I'm sending to you. Sir? Hello, sir.
Yeah, can you hear me?
Yes, sir. Sir, please send to my mobile, sir. Another number I've sent. Hi. My other phone is switched off. That's why. Please send to another number
Okay.
which I've sent. I will share it.
The slide?
Yes, sir. Slide.
Oh, wait a minute. Sorry for the.
Sir, actually your computer was visible, sir. Your slideshow, you should have gone there only.
Yes,
Dr.
sir.
Babu.
Pardon?
Yeah.
Arun,
You can
help
just
us, sir.
put your computer, I will guide you, sir. You show the slide and then go for the slideshow there.
Okay.
And share the screen option is there. Take that share the screen option. First you open your presentation, sir.
Okay, you can do that.
Your presentation is there, no, please?
Yeah,
In your laptop.
I'll in the mobile only. I'm actually. The problem.
Sir, actually, you had shared, sir. In the beginning, you had shared the screen, sir.
Yeah, I can do that, but now, oh shit.
Sir, first you open your presentation from the
Open
laptop.
the okay.
On the presentation you
laptop.
open.
Okay.
And then there will be option of share. Once you open that presentation, put on a slideshow.
Yeah.
And then you share with that, share the screen. There's an option in the link, share the screen.
For that, I have to open the link in the laptop.
Laptop.
No? Yeah.
You have got mail, sir? The link mail has come or no?
No, sir. I've shared through WhatsApp only, sir. Link.
It can be, he himself can get in from WhatsApp to his mail ID. And that link can be opened in the...
I sent it. Yeah. I sent that. I'm opening the link in the WhatsApp. Sorry, in the
laptop.
Launch meeting. In the laptop, I'm opening the link.
Yes, sir. And then share the screen is there, sir.
Yeah. It's not getting opened.
First open the presentation, sir.
I opened the presentation.
Now you put that share the screen on.
Now you won't be able to see my. Can you see my laptop?
No,
First you put the share the screen, sir. Madam, somebody who is organizing this webinar must give the share screening option to him.
No, sir. He is the
Sir,
host.
it's given, sir.
It's given, sir. He is co-host, sir.
Shobha,
Okay,
why
then.
don't you take the presentation and share it for sir?
Yes, madam.
Shobha, you can ask him to email the presentation.
It is seen, madam. It is seen.
He is doing. Open the presentation, sir, now.
Okay.
It's mobile.
ನಿಮ್ಮ ಸರ್ ನಂಬರ್ ಇದೆಯಾ ನಿಮ್ಮ
is there. It is getting open.
ನಂದು ಒಂದು ಮೊಬೈಲ್ ಕಳಿಸಿದ್ರು ಅದು
I actually opened in the mobile only.
Yeah. Now select the first slide, sir. Click on the first slide.
Okay.
Click on the first slide. Double click on the first slide. So that will be shown. Okay.
Can you see now?
We are able to see, but not full screen.
Not
all
full
slides
screen,
are
no?
seen. You do one thing, only one no you select, sir. Double click on the first slide.
I am not able to do that.
You click double screen, slide number 1.
It is actually
Sir.
seen like this only in the mobile.
Okay, sir. Please use the 3 dots top side, sir. Top right.
Okay.
Not this, sir.
Yeah.
Not this, sir. Earlier, previous
slide.
you used, no, sir?
Okay.
Yeah, 3 dots on the top right.
Nothing is happening with that. I'll send this to Shobha's another mobile.
Yes, sir. Please share, sir. I
Yes,
will.
sir.
Yeah, I'll do that. I send it.
Thank you, sir.
Okay. Yeah. It's audible? Is it visible?
Yes, sir. It's visible, sir.
Okay.
Sir,
Good evening,
is it a
everyone.
visual?
I'm extremely.
Hello,
Am
sir.
I audible?
Yes,
Yes,
sir.
Am I
sir.
audible?
Yes, sir. You're audible.
Yeah, can I proceed?
Yes, sir.
Yeah. Good evening, everyone. I'm extremely sorry for this technical difficulty. Today, my topic is on technical cesarean section, what is to be adopted. In the forum of a safe motherhood and reducing the incidence of cesarean section, this topic is also relevant. And indirectly or directly, this will be affecting the preventing the anemia, a safe motherhood, and reducing the incidence of cesarean section. Cesarean section. Next slide, please. I'll be covering this topic under introduction under these following headings. Introduction, technique of cesarean section, paradigm shift in the cesarean techniques, complications of cesarean section, what is the ideal technique, what is to be adopted, and take home message. Next slide, please. So cesarean section is more than 1,000 years old procedure. So it is started with the intention of separating a dead baby from a dead mother for the burial, and now it has become a life-saving procedure. It's the most commonly performed procedure in the major surgical procedure in the history of science. It has become life-saving for the mother, baby, and both. So as per the definition, the surgical procedure, this is a surgical procedure of removal of the fetus after the period of viability by opening the abdomen and the uterus, irrespective of the condition of the fetus. So, abdominal incision, it can be, and just we all know that the technique of cesarean section, various techniques are developed since the beginning of the cesarean section, and they start with the abdominal incision. It can be vertical or it can be transverse. After entering the uterine peritoneal cavity, in classical cesarean section, we open the uterus directly. In lower segment cesarean section, the uterovesical fold is opened and the bladder is pushed down to give an incision in the lower segment. After that, you deliver the fetus, deliver the placenta, and close the uterus. And after that, you close the abdomen. So now, this is the technique this is the basic technique steps followed in all cesarean sections. Next slide, please. So the paradigm shift in the technique of cesarean section. Initially, the cesarean section started with the classical cesarean section. Then it became lower segment cesarean section. And initially, in the beginning, only baby used to survive. The mother was left to bleed to death in the beginning of the cesarean section. Subsequently, it's only 200 years since the people thought of closing the uterus. So, in the technique of uterine closure has become an important step in saving the life of the mother. So, in the beginning, it was double layers because the classical cesarean section, the closure of the uterus with a single layer is not possible. The upper segment is so thick, and the double layer is then converted into a single layer, then interlocking and continuous non-locking. Then latest is the modified mattress suture, which is developed for closing the uterus. So when you're closing the uterus, you must understand that in the closure of the uterus, you must understand that there is no hollow viscous organ in our body which behaves like uterus. The heart is a hollow viscous organ, uterus is a hollow viscous organ, urinary bladder is a hollow viscous organ, and intestine is a hollow viscous organ. But when you close all these hollow viscous organs by surgical technique, the inner layer is a static tissue. So however you close it, it will heal properly. But in case of uterus, the inner lining is a shedding tissue. So if you trap that tissue inside the suture, it will never heal properly, and subsequently the chances of rupture of the uterus will be there, and that is one of the important reason for a repeat cesarean, because the scar, fear of the scar. So by having so if you look at this picture, here it is a double layer and single layer is on, and inverting a double layer is on. But all this technique, the inner layer is also included in this. So it is not the number of layers which is important. It is actually the correct anatomical approximation of the uterine tissue, which gives a good residual myometrial thickness, which is a deciding factor for the future vaginal delivery. So considering all these things, the modified mattress suture. Next slide, please. This is the modified mattress suture, which is developed by Babu and Magon. And here, if you see, there is no overlapping of the decidua or the internal layer, and there is a correct anatomical approximation of the uterine musculature, and which will give rise to a good residual myometrial thickness. Next slide. Look at the picture on the left side. Left side is the uterus, which is closed during cesarean section by conventional methods, double layer or single layer, or including the decidua. And this is the appearance of the scar. And this scar will not be able to withstand the stress of labor in the future pregnancy. So that is why people are scared of giving a vaginal birth after cesarean section in post-cesarean pregnancies. But if you see the picture on the other side, this is the uterus closed by the modified mattress suture and taken out by hysterectomy, and you can't even make out where the closure has been done. It is so well approximated, and the healing is so good that there is absolutely no thinning of the uterine scar. This type of scar is required for the future vaginal delivery. Next slide, please. Next slide. Next slide. Am I audible? Hello.
You're audible. You're audible, sir.
Yeah.
I think
Next slide, please. Next slide.
This is the last, I think, sir.
No, there are different slides. There are so many slides. No, there are more slides.
Correct. Arun, are you there, Arun?
Yeah.
Arun?
There are more slides. 1, 2, 3, 4, 5, 6, 7.
Arun?
8. Now 9 more slides are there.
Yes, sir. Yes, sir.
Mr. Arun?
Arun?
Madam, I am audible, ma'am.
Yes, sir. Please change the slide, Arun.
Yes, 1 second, ma'am.
Yeah. Some network issues, sir. Just a minute.
Yes.
Okay. So visible now? I'm audible?
Yes, sir. Yes.
Yeah. There's another technique of a cesarean section is a Mascova-Ledak technique. In this technique, the uterine closure and other things, other complications are not being considered. Only they have considered the time taken and the faster delivery and the duration of surgery, and all is being considered. Here the scar thickness and the residual myometrial thickness and other complications are not being addressed. Next slide, please. So what are the complications in cesarean section? Immediate complication is bleeding during cesarean section, and the late complications are everything is iatrogenic. That's the bladder complication. That means the bladder get adherent to the uterine scar, and the scar complication. The scar is not well healed. The fear of scar rupture in the subsequent pregnancy, and the incidence of repeat cesarean section being increased. Then adhesions. These are the complications of cesarean section. Now, how these complications are happening? Why these complications are happening? How can we prevent this? So if we prevent all these complications, and if we can have a technique of a cesarean section without these complications, and that will be the ideal cesarean section, ideal technique of cesarean section. Next slide, please.
Arun, next slide.
What are the key steps which leads to iatrogenic complications? One is after opening the abdomen, we always conventional step is to open the UV fold and so pushing the bladder. And now the question is it actually required to do a lower segment cesarean section? If you don't open the UV fold and do not push out the bladder complication of the post-cesarean pregnancy will not be there. And for the last 10 years, I have never opened the UV fold separately and pushed the bladder for doing a cesarean section. At the term uterus, the lower segment is 9 to 11 centimeters. My question is why you...
Sir, unmute yourself, sir. You're muted. Sir, you're muted, sir. Please unmute. Babu, sir, you're muted. Babu, sir, you're muted. Unmute yourself, please. Arun?
Yes, madam.
Sir, ಮಾತಾಡೋದು ಕೇಳಿಸ್ತಾ ಇಲ್ಲಲ್ಲ?
ಇಲ್ಲ madam.
ಅಲ್ವಾ?
Yes, sir.
Now we are audible, sir.
Hello.
You are audible
Yes,
now,
sir.
sir. Till now you are not audible.
So so the opening of the UV fold is not required to give an incision in the lower segment to do a cesarean section. And second is the closure of the uterine incision. That how well you close the...
Sir, you are muted, sir.
Yeah. Hello.
Yes, sir.
Yes, sir.
Yeah, audible. Yeah, opening of the UV fold is not required for giving a cesarean or doing a cesarean section. Then comes the closure of the uterine incision, where if you don't close the uterine incisions properly, there will be a scar complications. And another complication that happens during cesarean section is the bleeding. After the removal of the placenta, even 1 liter of blood is acceptable. But if there is any measure to reduce the blood loss during cesarean section, why don't we adopt that? Next slide, please. Another thing is the cosmetic aspect. Every surgeon should have a cosmetic attitude, but the cosmetic aspect is rarely considered during a cesarean section. At the time of cesarean section, cosmetic is least important. So we most of the time don't consider about the cosmetic aspect of cesarean section. Now, what is an ideal technique of cesarean section? If it is cosmetically good, there's no bladder complication, no scar complication, and if you can allow all the post-cesarean pregnancy to the VBAC, that will be the minimum blood loss during cesarean section. That will be the ideal technique of cesarean section. Is it possible? Next slide, please. So, is it possible? So,
Sir, you're mute.
Am I audible?
You're audible now,
Yes,
sir.
Yeah, okay. In between some calls are coming. Sorry for the disturbance. Am I audible now?
Yes, sir.
Okay. So abdominal incision. So can we have an ideal cesarean section without all these complications and with the safety of the patient? So abdominal incision, starting with the abdominal incision, what type of incision? Whether it is vertical or transverse, you can have a transverse incision for a cosmetic purpose. Then opening of the UV fold and separating the bladder. Hello, am I audible?
Yes, sir, you are audible.
Hello, yeah. Opening of the UV fold is not required, and pushing the bladder is not required to do a cesarean section. If you avoid this step, there will be any bladder complication in a post-cesarean pregnancy. And opening the uterus, whether using the knife, scissors, or finger, these things have not made much difference. But you should be having a clean cut of the incision. Then that will be better to close. It is easy to close properly. Then the uterine closure technique, you should adopt the technique which gives a best residual myometric thickness. That is the modified mattress suture is the one which is giving a best residual myometric thickness as of today. So then closure of the UV fold of peritoneum, it is in my uterine closure technique, the modified mattress suture, peritoneum is also included with the uterine musculature. So it is actually being closed. And closure of the vesicle fold of peritoneum, if it is not opening, it is not required to be done separately. And the abdominal closure, if you approximate the rectus abdominis muscle, then that will prevent the future chance of divarication of the recti and the lax abdomen. So, next slide, please. So, an ideal technique of any surgical procedure should have a best outcome and the least or no complications. So, an ideal technique of cesarean section should have a cosmetic abdominal incision, no bladder complications. Uterine closure technique is the best residual myometric thickness and allow for a VBAC unless there is a contraindication for vaginal delivery, and there should be minimal bleeding in the cesarean section. So, all these things are possible. Next slide, please. Next slide, please. All these things are possible by picking up the best techniques from all levels and integrate into a single technique. All these things are possible, and we can have a safe cesarean section. For example, the incision should be fan and steel on the skin, and entry method is by Miskava Ledak technique, by entering the abdominal wall, by separating with the finger and the opening the peritoneum with the finger, then without opening the UV fold of peritoneum and without separating the bladder, give an incision in the lower segments, and use of a uterine holding forces to reduce the blood loss using cesarean section. Even if the blood loss is 1 liter is permitted, if I can have a cesarean with the 200 ml of blood loss, you should adopt that. That will prevent the long-term anemia of the patient also. Blood loss, prevention of the blood loss will go a long way in preventing the anemia. The closure of the uterus by modified mattress suture, the UV fold is also taken along with the uterine closure. Next slide, please. So then approximate the rectus muscle to prevent the divarication of the recti, skin closure by glue or a subcuticular suture. These techniques will have a cosmetic scar, minimal bleeding, and prevent atonic PPH, no bladder complications, and good residual myometric thickness to allow VBAC in the next pregnancy, thereby reducing the rate of repeat cesarean section. Next slide, please. Thank you.
Sir, can you elaborate on your uterus holding forceps, sir? By that we can reduce the...
Uterine holding forceps, it's a compression. I'll put the uterine holding forceps is an instrumented device to compress the uterus after the delivery of the placenta. This will reduce the blood loss during. Am I audible?
Yes, sir, you are audible.
Yeah, that will reduce the blood loss during cesarean section and prevent atonic PPH also. So immediately after delivery of the placenta, we always follow the active manner in the third stage of labor. And any patient, the uterus is relaxed. Even if the patient does not develop PPH, even saving the blood during the cesarean section also go a long way in preventing the anemia of the patients. I want to ask you people, when you are doing a hysterectomy, if the uterine is bleeding, which is only 1 or 2 millimeter diameter blood vessel is bleeding, you become panicky and catch the bleeder. Then why don't you do the same thing when you are doing a cesarean? the placenta site bleeding can be, a torrential, which is, since you are not seeing, we permit the uterotonist to take care of that job. So why don't you use this mechanical this thing to prevent the blood loss? Even minimal can be reduced to, if you use this uterine holding forceps, average blood loss during cesarean section is 150 to 200 ml only. So if you routinely use this instrument during cesarean section, blood loss can be significantly reduced. Since we are used to the liters of blood loss, we don't generally don't bother. And moreover, visual impression of a blood loss is almost always underestimated. When you feel that the patient has lost 100 ml, 1 liter of blood, he must have already lost 1.5 liters. So instead of allowing the patient to bleed and measure, why don't you prevent that? So by using the uterine holding forceps in routine cesarean section, all the cesareans, that will significantly reduce the blood loss during cesarean section. It is, though I invented for atonic PPH, I am using it routinely in cesarean sections, and that in fact stops the bleeding instantly once I apply the instrument. So you can reduce the even minimal blood loss also from the placenta surface. There's a video of this uterine holding forceps available in the YouTube. I will share it with you later.
Okay, sir. Thank you, sir.
Okay.
Shanta, madam.
It was an excellent presentation by Professor Babu, sir. He gave importance of reducing complications of the bladder. Sir told not to separate the bladder peritoneum, UV fold. And also the different techniques of uterine closure. And also Sir spoke exclusively on uterine holding forceps. I think Sir meant about the green Hermitage forceps, sir? Was it?
Pardon? Your sound is not clear, madam. Sound is not clear.
Madam, there is a lot of disturbance, madam.
The uterine holding forceps is green Hermitage or what?
Not green Hermitage. It's a uterine holding forceps I invented and patented.
Okay,
Madam,
okay,
it
okay,
is
sir.
Madam, it is like a big spoon-like structure, madam. It will compress the uterus from anterior to posterior. I'm using it, madam.
I'll just send the Dr. Shobha Shivi is having that instrument. You can have a look and use it, and it is just giving a bimanual compression. That's all it is doing. So that's what I asked you when you do a hysterectomy. The bleeder is there. You cast the bleeder with the artery. Here you cast the bleeder with this uterine holding forceps from the placental side.
Okay, sir. Okay, sir. And
the advantage the uterine closure technique is this modified matter suture is basically concentrating the correct anatomical approximation, that is serosa to serosa, muscular to muscular layer, and the deciduous to deciduous. The deciduous is not included in the this thing. That is why it's giving a good residual myometrial thickness. A recent randomized control trial run in Iran in 2022 has proven that this technique is the best technique, and that gives a better myometrial thickness.
Okay, sir. We will see your videos in the YouTube.
Yeah.
And also
the
rectus muscle to just approximately.
Just to approximate. Suppose you do a cesarean follow in a twins or triplet. I mean, there must be a divulgation of the recti. If you approximate the rectus muscle at that time, the cesarean section, you just put the 1 or 2 interrupted sutures, including the peritoneum and the rectus muscle. It is not a continuous closure or something. Just to keep the muscle approximated so that they heal like that, and there will not be any divarication of the recti.
Okay, sir. Thank you so much, sir, for elaborate discussions. Thank you.
Yeah, these things are not given in the textbook. What I have done is, whatever the evidence is available, I mean, you're taking out the best of all technique and amalgamating in a new technique so that you can have a cosmetically good, the less blood loss, and all the patient who has undergone a cesarean section should be able to do a try for a vaginal delivery unless there is a contraindication. This was the aim of modifying this new technique So if you practice all this, because these things are not given in the book, and nowadays everything is given on the basis of the evidence. Whatever is evidence is available, you are not ready to follow. So these are all evidences are available. It is just a mindset. It's just an attitude. Like a cosmetic is an attitude. Every surgeon should have a cosmetic attitude, but we leave the cosmetic attitude only towards the plastic surgeon, cosmetic surgeon. We all are supposed to have a cosmetic attitude. This chalta hai attitude will not work.
Shobha, can I?
Yes, madam.
Yeah.
Yes.
Sir, it was a wonderful presentation, a practical aspect though. I just have two questions, sir. One, for a previous C-section, a scar integrity, do you actually check by ultrasound the scar integrity and then proceed with
Always. For my cesarean section,
Do you have your own guidelines for that, sir?
I have my own guidelines. All the post-cesarean pregnancy, I assess the scar thickness at the 12 to 13 weeks. After doing a cesarean, I always do the scar thickness after 6 months and tell the patient that whether she can undergo a VBAC or not.
Okay.
This is a routine procedure give. I
Yes.
measure the scar of the cesarean section after every month, every case I do.
All right.
And in a post-cesarean pregnancy, which is done by others, comes to me, I do a scar thickness, and if the scar thickness is not good, I will not allow the patient for a VBAC.
Yes, sir. So the second question is, lot of times the previous sections when we open up again, we have issues at the level of the muscle. Now, previously, last week I had a case where after 24 hours after section, I was called in for the bowel distension. So what has happened is they try to actually approximate the muscle. So in between the gap, I think there was a bowel which was post surgery, which was just looped in, and that was gangrenous. So, what is the take on the approximation of rectus? What you're speaking about, sir? Many a times it's not easy for us to approximate the muscle.
Approximation of the muscle over that you are crossing the rectus sheath also.
Yes.
So there is no question of
The
there is no
muscle is
question
what
of
I'm asking,
bowel
sir.
loop. That's what I'm telling you. See, the muscle which is coming, the bowel which is coming into the, which is very, very rare because there is a covering of the rectus sheath over that.
Yes.
So how the bowel has gone into that? It must
Because
have just
in
gone into
between the
the
muscle, they have taken the stitch, and in between the stitch, there is a bowel which was entangled. So, is it wise to, suture interrupted muscle or leave it like that?
I have not seen a case like that. And why this thing is once the anesthesia is gone, the muscle tone has come back. So the similar thing can happen even if you don't stitch also.
Yeah, okay.
Even if you don't stitch also, similar thing can happen, na?
Yes. So there may be sometimes like cases we have seen there is distension post.
If you should do at least two interrupted sutures in such a way that there should not be any too much of a distance.
Gap. Yes, sir.
At least two or three interrupted sutures should be taken so that there is no gap between the, and moreover, once the anesthetic effect is gone, the muscle will come back to the normal tone. So my intention of approximating this muscle is, if the muscle is too far away from a over distended uterus, just to keep it in such a way that it will start healing in that level.
Correct. And the Misglaive Zara technique, what you said, sir, your take on exteriorization of the uterus, because most of the time we see there is a hypotonia again, and the uterus is not well contracted when it is exteriorized.
I almost always take out the uterus during cesarean section. The reasons are easy to manage. To apply my uterine holding forces, I have to take out the uterus, and you can see the tubes and ovaries, and it will be easy to manage. All these things, suturing is also will be easy.
Thank you, sir. Thanks, Dr. Shobha.
Yeah, and you must have seen cases after doing a cesarean section 1 or 2 weeks later, patient come back with an ovarian complication we have not seen. And I ensure that whether I do a hysterectomy or a cesarean or whatever laparotomy I do, I always ensure to see the other organs also. I see the appendix, I see the fallopian tube, I see the ovaries, I see the bowel also. I made it a habit to do that. So it is, there is no, the appendix is just in front of you. There is no problem in just seeing the appendix. suppose the patient come back with a appendicitis or abdominal appendix, it is always better to do, even when you're doing laparoscopy also, I look at even if I'm doing a laparoscopy in the pelvis, I always do see the liver and gallbladder and upper abdomen, always.
Thank you so much, sir.
Thank you, sir.
Yeah,
Thank
when
you
you
very
take
much.
out the uterus, getting an opportunity to see the ovaries.
And also the posterior surface of the uterus.
Yes.
Thank you, sir. Thank you very much, sir. Now we have come.
Welcome.
Now we have come to the fag end of the session, and it's been a very long.
Dr. Babu.
Yeah, yes.
Well,
Yes,
sir.
sir.
Really, sir.
Yeah, I just want to add on to the answer what he gave for the Sonia Mandapa's case of post-cesarean gangrene. So I just want to add what you said, Dr. Babu, that interrupted closure of the rectus muscle should be like a figure of 8 if you take 2 stitches. I call that cross mattress sutures what we take. And either you can include with the peritoneum, without peritoneum.
Yeah, I always include the peritoneum because we don't separate the peritoneum. So that also comes along with the muscle.
Yeah, once you take 2 stitches, we can just approximate the whole length of that. And there will not be in between any space. Sonia, don't put interrupted suture. Take a cross mattress suture, what we call that, and or figure of 8 suture.
Figure of 8. Figure of 8. Yes.
Approximate.
Yes, sir. I brought it to the notice only because we should not be thinking of any other complications when there is a case referred to us post section.
You are absolutely right. You are absolutely right. The purpose of this type of conference is that only. You have to discuss the issues and.
Thank you so much, sir.
Okay.
Thank you, sir. Sir has invented many instruments which are very useful in day-to-day practice. You can visit his YouTube channel. There's a video of many of his techniques and also instruments. So thank you, sir. Thank you, Bella, sir, for your inputs. Now we have come to the fag end of the session, which has been a very, very long session. And I would like to take this opportunity to tell about our committee. It's been 1 year since it joined this committee, and we are thankful to MG sir, MG Hiremat sir, Vidya madam, and Rajeshri madam for supporting us in all our endeavors. We have done a Vistrit project, which was very much well received and appreciated, and we have also done many webinars. And I'm very grateful to all the advisors of the Safe Motherhood Committee, Dr. Hema madam, Dr. Kasturi madam, Dr. Nagratna madam, and Dr. Sonia madam, who have always supported us. And also I thank all my committee members for being there in all the endeavors and actively participating. Now I call upon Dr. Jyoti GS madam, who is the senior member of our committee, to give vote of thanks.
Thank you, Dr. Shobha. Good evening, one and all. It's my proud privilege. Yeah, it's my proud privilege to deliver this vote of thanks for this wonderful August gathering. At the outset, I thank our chief patron, Dr. MG Hiremat, who has been the real pillar for all the committees and spearheading for all of us, spearheading all the committees to do more and more very good quality academic activities. I thank Dr. H. Nagraj, our patron, with whose blessings we are always inspired and motivated to do more. My sincere thanks to Hema madam, Hema Divakar madam, as rightly said, she is the icon of the Foxy and the Ksoga, and we know her digital platforms where she has empowered so many paramedics across the country and taught them all about preeclampsia, gestational diabetes, and other obstetric emergencies, and empowered them. My thanks goes to Bellet sir. He is the president of KCOG. My most important person here today, who I can say is a heroine, is Madam Bharti Rajshekhar. She has been installed as the president of Ksoga. Thank you, madam. I am sure with your guidance, we will go far and better. My sincere thanks to Preeti Kumar, our ex-chairperson of the Safe Motherhood Committee of Foxy. Always, she's such an affectionate and wonderful person, guiding and mentoring us. My real mentor, Dr. Vidya Tobi, who has encouraged me so much, always, the past president of Ksoga. Thank you so much, madam. I thank Dr. Rajeshri Palladi, the secretary of Ksoga, and Suman Gaddi, treasurer of Ksoga. My friend Sonia Mandappa, she is now the secretary of KCOG, and she's a very active and dynamic person. As you are seeing, she always brings about spice in any event, academic event, and always doing all these wonderful activities, initiating them is our Dr. Shobha, who is the chairperson of the Safe Motherhood Committee of Ksoga. Thank you, Shanta Shekhar, madam. She is the South Zone Executive Committee member. All of us know Shobha Gudi. She's a very good orator, extempore orator, and she has nicely illustrated on how to bring down the cesarean section. So, Babu sir, your talk was very nice. I learned all the tips and tricks. You were a real, very good contribution for this session. It was wonderful, sir. And I thank all the other members of this. Thank you, sir. I thank all the other members of the Safe Motherhood Committee who have always pitched in. And they are also very, very important for us for the programs to be successful. Last but not the least, I thank Arun. Always, he's working behind the screen for making this Ksoga platform successful so that we all come together and conduct the program successfully. Thank you, one and all. Thank you, Dr. Shobha, for giving me this opportunity.
Thank you so much, madam.
I've mentioned everybody's name.
And all the delegates patiently listened.
Yes, of course. That is very, very important.
Company was sponsored.
The company,
and the
was
company,
Curomed. Curomed. We need somebody to sponsor our program, and they are also very vital for the program. Thank you so much.
Thank you, madam. Thank you so much. Thank you, everybody, for patient listening. See you all. Bye.
Thank you very much, madam. Dr. Jyoti.
Thank you,
You've
Sonia.
always been